Good morning, everybody, and welcome. My name is Sarah Cott. I'm the Senior Vice President of Programming for The Hill, and I am delighted to welcome you all here to the U.S. Healthcare's annual checkup. I'd like to thank our sponsors, CVS Health, AstraZeneca, and Novo Nordisk, for their support of today's event. We are convening this morning at our biannual Healthcare Summit, exploring the intersections of health and politics. Today, we will cover many topics, including maternal and mental health, the doctor's shortage, rising healthcare costs, the consequences of an aging population, game-changing treatments for cancer and weight loss, and the role of AI in healthcare, as well as medical disinformation. Today's guests will include members of Congress, the administration, medical professionals, and healthcare advocates. But first, a few housekeeping rules. In addition to our audience here in the room, we also are live streaming this event on thehill.com. Please keep your phones on silent for the duration of the program, but please feel free to join the conversation on social media. You can follow us on social media at The Hill Events, and we will be using the hashtag #TheHillHealth. Oopsie. Now, it is my pleasure to welcome Cheyenne Daniels, The Hill's race and politics reporter, with our first guest, Congresswoman Robin Kelly of Illinois. She leads the Congressional Caucus on Black Women and Girls and sits on the House Energy and Commerce Committee and its Health Subcommittee. Welcome, Congressman Kelly. Thank you.
Okay.
That's fine. Oops. That's fine. So we have titled this section with you as Putting the Care Back in Healthcare, as a nod to your Cares for Mom Act. Can you just talk to us a little bit about what that legislation is?
Sure. This is the part 2 of the legislation I worked on called the Mamas Act, which has been a few years ago now, and we got some things passed out of it, but we felt there was more to do. So my district, if you know Chicago's urban, I know you do, urban, suburban, and rural. So I start on 43rd Street in Chicago, and then I go south of Danville. So people say you have Chicago, but you also have 2,000 farms, you know, in your district. And there are parts of my district that you could call maternal healthcare deserts. And in the more rural part of my district, and one of my biggest towns of like 30,000 people, there's only one OBGYN. So we want to do things like mobile healthcare units to help with that. I have constituents that would have to drive an hour or more to get access to health care. We also think it's important when you talk about telehealth that I've spoken to OBGYNs that use that now because so the patient doesn't have to come in, but also we have to make sure people have broadband because some parts of my district don't have that either. So it's all wrapped in together with the different laws that have passed that will help everyone have access to broadband and they can have telehealth. But the Cares for Mom Act, we also want to promote the ideas of doulas more. So many people that we've had testify that had problems with birth and talked about how the next time doulas were really helpful to them, to advocate for them, to be there for them, to be there even after they've had their children.
You mentioned that there are some areas where there's only one OBGYN. Are people aware of this for those who aren't living in these areas?
I don't think so. I mean, before I came to Congress, before a constituent called me, I didn't even realize maternal mortality and morbidity was even a problem. It was Judge Hatchett that I was introduced to that you see on TV. She lost her daughter-in-law. That's how I became aware of it, and we hit the ground running, had forums and different things like that. So no, I don't think that people are aware. I think that the news is doing a better job, though. I've seen it more and more about maternal mortality and morbidity in the United States, in particular with Black and Native women. It's really bad.
Mm-hmm. Yeah, and I wanted to get into that because the maternal health crisis that we have right now, I think Black birthing people are 3 to 4 times more likely to die from pregnancy-related causes.
Depending where you are, it could even be higher.
And it can even be higher in some areas. And we also know that Black infants are twice as likely to die within their first year compared to their white counterparts. Talk to me a little bit about what we're doing right now in Congress. I know you're with CBC, the Brain Trust. Talk to me just a little bit about where these priorities are to end these disparities.
Well, it's definitely a priority, and we help lead the decision where states could expand their postpartum coverage for Medicaid. It was just 60 days, but so often mothers run into trouble, have postpartum depression, their physical health occurs, the demise occurs after 60 days. People just don't die on the table. It's not just then. So now the coverage, if the state chooses to do it, it's for a year. And I never thought this was going to happen, but now we're at 40 states that have expanded coverage for a year. But we want to see in our CARES Act that every state has to do it, and the District of Columbia also. So only really 10 states to go. So we're thrilled about that, and we know that will save lives. But no, it's definitely a priority. I mean, I lead on it, but there's other members of Congress doing things around the issue also.
We know that the Centers for Disease Control and Prevention have pointed out that many of the illnesses that are leading to these deaths are preventable. So what are some of the reasons why we're seeing such high rates of maternal mortality?
Well, I don't know if you saw the report, but 84% of the deaths are preventable.
Wow.
And again, there's access reasons, there's systemic racism reasons. We've heard reports even from Black female doctors that are having babies, the not being listened to, or Black women can take more pain and those kind of things. But also there's the hypertension, overweight, those kind of things too that lead to it. But again, women have to be listened to, educated. They have to have access to health care to know, this is what you need to do and this is not good. High blood pressure, all of those kind of things lead to it also.
Many parts of our country are still grappling with the Supreme Court's decision to overturn Roe v. Wade. Can you talk a little bit about how access to abortion or reproductive health care is important for ending the maternal mortality crisis?
Well, healthcare professionals and advocates that I speak with do feel that because of that decision, then we'll see a rise in maternal mortality or morbidity, because you're forcing women, or it could be, teens, to have babies that, they don't want to have, So that decision is very scary for a multitude of reasons.
And I want to take a little bit of time very quickly because, and you mentioned this a little bit about some of the mental health effects that arise with some of the reasons for the maternal mortality, including depression. So what are we looking at right now when it comes to Congress helping to provide for mental health services?
Well, that's part of also the bill, and I'm the co-chair of the bipartisan Maternal Health Caucus, and that's one of the things that we're looking at, more mental health services for either pregnant moms or moms that have already had their children. And we have to make sure that in this culture that the stigmas are decreased, because we think that's a reason people don't do it, and when you have a baby, that's supposed to be your happiest time, supposedly, and that's not the experience of too many moms, you know what I mean? And moms do commit suicide or postpartum depression and things like that. So we are trying to, in all kind of ways, not just with moms, but provide mental health services, and hopefully the postpartum coverage to a year will help with that. But I think for the stigma, we have to start so younger so that people know that it's okay to seek mental health, starting it in schools, having counselors and therapists in schools, which we're trying, to do that also, and just provide it so that's just a natural thing. Like when you break your arm, you go to the doctor. That if you're, feeling like you need someone to speak to or you're going to harm yourself, that you know that it's natural to speak to someone to, or that it's okay.
What are some of the treatments or therapies or breakthroughs that you're really paying attention to at this point in time?
Well, actually, we just got involved a couple of weeks ago. We had a roundtable in the district dealing with food as medicine. And we think, it's not always a pill that maybe we should go to first, but look at, what we're eating, what will help, with our weight, with our blood pressure, with heart disease and those kind of things. And can we be eating different to help with those ailments?
Oh, I like that. That's super interesting because we always hear our doctors talk about, oh, how's your diet? Are you eating healthy? Are you exercising?
Right.
Things like that. And we don't always make that conclusion that perhaps food could be a pill, for lack of better words.
Well, and also when you think about, we talked about maternal health deserts, but just the food deserts, that exist. And food deserts exist, urban, suburban, and even rural too, where you think you have farms, but we've heard people say, they can go to the gas station and get their banana or their apple and, those kind of things. So, the top 10 diseases that Americans die from, African Americans are number 1 in 8 of the 10. So when you think about, maternal health issues and other issues, high blood pressure, heart disease, those kind of things, food would help if we could eat, healthier, but also it has to be around us. We have to have access.
Many of the conversations we discussed are disproportionately affecting communities of color, Black communities, Indigenous communities, Latinx communities. How do we begin to sort of draw that racial justice line through these topics, whether that's maternal health care or food deserts?
Mm-hmm. I think that we are, those of us in the communities or representing the communities are bringing this to the forefront more and more. We just have to make sure we, pass legislation or provide resources to underserved or unserved communities so they have opportunity and they have hope. That, my gun violence prevention is, beside maternal mortality, a big passion of mine. And when you speak to young people in the communities, they don't have the hope, they don't have the opportunity, they don't see the same things as, other people see, even though gun violence is all over now. But I think that we have to do a better job in providing, good education, mentors, food, access to food. When you think about how many people go to sleep at night and they're hungry, how many kids go to sleep at night and they're hungry, that all has an effect on your development and your thoughts and as you grow to be an adult.
Today's theme is U.S. Healthcare's annual checkup. How would you rate the overall health of the American healthcare system?
Well, you know what? I think in ways location, depending on where you are. That's the shape of the system. Some parts of where I represent in Chicago, if you want to have a baby, you have much fewer choices because people are closing down their maternity wards. If you have to drive an hour, sometimes 2 hours to get to an appointment, and you can't do telehealth for everything, so I think it depends on where you live. And actually, we just put out something. I'm trying to I can't remember every state, but it was states where CBC members live And I'm trying to think, I don't know if anybody received an A. I'm trying to remember, but so there's a lot of room for improvement.
Congresswoman Robin Kelly, thank you so much for your time today. Really appreciate you being here.
Thank you.
Thank you, Congresswoman Kelly and Cheyenne. Now welcome Bob Cusack, Editor-in-Chief of The Hill, to the stage. Our next guest has spent the bulk of her career focused on healthcare innovation. Please welcome, well, we'll let Bob go. Please welcome the Deputy Director of Advanced Research Projects, Agency for Health, Dr. Susan Moneres, and Bob Cusack. Welcome.
Hey, good morning, everyone. Thanks for coming, and thanks for doing this, Susan.
Absolutely. Thanks for having me.
A lot of people in the room know what your agency does, but a lot of people watching that do not. So could you briefly kind of describe the mission of ARPA-H?
Yeah, so the mission of ARPA-H is to occupy this unique space in the health innovation ecosystem that is not covered by our incredible traditional R&D investments that would be made at NIH and at CDC and FDA and other places. And it's not quite industry. So we're not going to be doing things that are going to translate into an ROI, next year or the year after. But what we're doing within ARPA-H is we're working in this space where no one else is working, where we're not going to have, a 10-year sort of grant-based process to invest in some aspect of the health ecosystem. And I loved what Sarah said when she was introducing this section is we know there are critical areas in the health ecosystem that are under-resourced, that are under-addressed in the R&D and the innovation space, like maternal mortality, like we just heard from the Congresswoman, rural health, mental health, our ability to treat cancer and Alzheimer's and all of these other urgent issues across the health ecosystem. And that is where we are going to occupy that lane. We are going to take big bets on high risk, high reward. It may work, and if it works, it is going to transform the health ecosystem, in 5 or 10 years. We will take something off the table. And so we're sort of, you could think of us in between sort of the steady state building knowledge and really trying to contribute to the broader base of understanding of the health ecosystem and an industry where they're just churning through the last mile to get something into the commercial market and get it into the patient population. Does that help?
It does. It does. So big topic, healthcare innovation.
Yeah.
And if you think about really the last 50 years in healthcare, there's been a lot of innovation.
Yep.
And there's a lot more coming.
Yep.
So what's the best way to foster it and also, also make it safe?
Yeah, no, it's huge questions. So the way that we're thinking about this within ARPA-H is that we want to have full visibility and understanding of what has come before. If we invest in something, what are the potential impacts that it will have? And we are fully embracing the ability to integrate data, whether it's through AI, ML, or through traditional data resourcing, health economics modeling, into our portfolio management. Because it's the only way we have been afforded resources through our great partnerships on the Hill. The appropriators have provided us about $1.5 billion of annual funding over the past few years, which is fantastic. And we think we can really get in there and do some great work within our portfolio. But that the R&D ecosystem is $200–300 billion of annual investments across just health and life sciences R&D within the larger context of a $3.5 trillion health ecosystem. So our $1.5 billion portfolio has to be really incredibly well informed. Cannot be unnecessarily duplicative of other work that has come before us. And it can't be chasing something that the commercial sector is also, to your great point, Bob, is already innovating in. If there's something that's already being, invested in and is full speed ahead out in industry, we have to occupy a more narrow focus. And so we are embracing, all of the tools to help integrate this data to inform us to make those best decisions.
Well, speaking of tools, let's get specific on AI, which is a very difficult topic, I think, to get your head wrapped around. We do a lot of events every year. We're talking about AI at every one of them.
Yep.
How is AI going to affect health outcomes in the next 5-10 years?
Yeah. AI, if used appropriately, in a disciplined way, in a way where there is an actual human check and balance on anything that's coming through a predictive or a generative model, will completely transform healthcare. And let me just give you some examples about that. When you think about diagnosis of a patient when they come into a clinical care setting, we know that there is misdiagnosis on a non-zero basis across the clinical care space. So if you come in and you're being seen as a patient and you happen to have certain indicators of an illness or of a disease, 20% of the time or so, your clinician is going to say, well, we think you have X, not Y. When we actually integrate, and this is something that we're exploring within ARPA-H, it's also something that's being explored in the commercial market, and again, we're going to occupy a different lane. If you can actually integrate the individual patient information, integrate it into the larger understanding of patients or individuals with symptomology similar to them that is extracted from electronic health records or from other sources of information, whether it's wearables or community health information related to various health-related social needs, social determinants of health, all those, imagine all of that integrated. And so that when you go into a clinical care setting and you have X, Y, or Z symptomology, your clinician can understand in 5 to 10 minutes through a generative AI, through a modeling capability. We actually don't think Bob has the flu. We think Bob has something else. And it is incredibly well informed. And so Bob walks out of there knowing that his best course of treatment is going to be the next 10 things and how he's going to get those things because you've actually introduced him into the clinical care pathway that is most meaningful for him. Bob is going to have a much better health outcome than he would have had he had to go to a serial number of engagements in a clinical care setting and not having the right diagnosis month over month over month, potentially year over year over year, which we know happens. And so in this particular case, Bob is going to be much healthier, much more quickly than he had delayed diagnosis in a not optimal treatment regimen.
One example of kind of the advances is if you had told me 20, 30 years ago that we're going to be able to develop 3D printed, fully functional human organs.
Yep.
I mean, I Googled that when it was in, and the staff helped me with the research, and I'm like, that can't be right. And I used to cover healthcare, and I must have missed it. But what is the potential for that, and how soon is that going to happen?
Oh, I love that question. So I'm gonna give you a long answer to that awesome short question. So the long answer is part of what we do in ARPA-H is it's not completely random, high risk, high reward research. There have to be enough embers of reality in the science that if put together in a different way could result in this transformation. So when it comes to 3D printing organs, there are enough embers. We've been investing in the pieces of how would you actually do 3D printed tissue? How do you know enough about the biochemical structure of a heart? Do you know enough about how you would actually layer the tissue together? Do we know enough about viability of an organoid long term? Do we know enough about how we would actually do the transplantation? Do we know enough about the immunology that you print a histocompatible heart for anyone who needs it within 30 minutes of them needing it? The answer to all of those is yes. We know all of the embers that are necessary to, when put together with a brilliant program manager, the right partners out in the ecosystem, that we could actually have a 3D printed heart. I'm not saying it's easy, because if it was easy, we wouldn't do it, right? I mean, this is going to be incredibly challenging, but we believe that if we take the right performer teams with this incredible can-do attitude, and we compress all of the great knowledge that's already in existence about this domain, and then we say, we're going after this. And we go after it not in a grants-based way where it's best effort and let us know how it's going and keep us apprised. We go after it in a contractual relationship where we say, these are the things we want to see from you as a performer in 3 months. We want to see it in 6 months. We want to see it in a year. We want to see it in 18 months. And we'll pull a plug on something if it's not making the progress that we think. So it's not funding in perpetuity. we will learn something from it. We'll say, okay, well, we thought we were going to be able to do X, Y, or Z thing, and it came short of that. But we really were, it's one of our big bets, and I really think knowing who's going to be involved in this, that we're gonna be successful.
In these advances in technology, how do you ensure, and obviously that technology is not going to happen tomorrow,
Yep.
but when it does happen or other innovations happen in the next year, 2 years, how do you ensure, do you work with other government agencies, or does your agency focus on how do we make sure this is accessible to all populations, including vulnerable populations?
Love that question. And we make sure it's accessible in a number of ways. The first thing is we do absolutely partner with our counterparts across the federal government. So we are informed by not only accessibility issues, reimbursement issues, we're informed by FDA regulatory processes. We understand they have an incredible mission to make sure that anything that's developed is both safe and effective for the patient population. So we're working intensely with them. We're working with CMS on reimbursement to ensure that it's not so cost prohibitive that we can invent this amazing technology, but the only people who can afford it, are people who happen to be in the, as the Congresswoman was saying, in the right zip code. They have the right private health insurance. They can pay out of pocket. That is not where we want to place our resources, and those are not the results that we want to achieve. And we do it not just through our partnerships within the federal government. We also are working closely with our investment partners. So as we build the technology, we want to transition to someone who also has that same ethos, that they want to make this broadly accessible to the entire patient population who would benefit from it. So we work in there. And then one of the foundational principles, even as we're talking about where do we place our investments, we anchor ourselves in who benefits. Who will benefit from this technology? And unless the answer is everyone who deserves access to that therapeutic, the diagnostic, the treatment, is going to be a really hard sell to move anything forward within the agency. And we actually build that out as one of our core questions that we ask. It's Heather Meyer 10 question, so that we say, is this broadly accessible to everybody who has the need to have it? And it is a go, no-go decision within the organization.
ARPA-H has initiatives on clinical trials. Can you tell us a little bit about that and its ultimate goals?
Yeah, so, and I love that you're asking this right now, because we are still in the process of figuring out what right looks like. So we know we're going to advance clinical trials. We've been working with our colleagues at the Office of Science and Technology Policy, who had really launched this initiative of how do we advance clinical trial readiness in the wake of a pandemic. So we know that during the COVID experience, there were challenges and limitations about having clinical trials accessible to the entire patient population. And there was, challenges that were overcome over time, but we don't want to be put in that place again. So that's where we started from. But as we were thinking about it from the ARPA-H perspective, is what can we do to ensure that at steady state, not just in response to a pandemic, but at steady state, that we have an open and inclusive and a fully benefiting clinical trial network, so that we can ensure that it's equitable, that it's accessible, that it isn't just skewed towards a demographic or a geographic or a patient population, but we actually have an inclusive clinical trial network. We just closed an RFI that we had pushed out to we launched a few hub and spoke networks to be able to have ready access to individual entities within the health ecosystem that we think are going to be critically important to help advance ARPA-H issues. We pushed this out as an RFI, and we said, tell us what clinical trial challenges that currently exist. Tell us how we can make it better. We're going to synthesize that. As you probably, Bob's about to ask me, there's a lot going on in this space. Susan, how are you occupying a new space? Once we get the RFI back, and once we actually say, okay, so where is the unique area that ARPA-H could invest in that's not duplicative of what's happening in the private sector with Walmart's amazing clinical trial network that they're investing in, or NCATS, our National Center for Advancing Translational Science partners at NIH, which already has clinical trial network that they're working on. Where is our space, and how can we enable the investments that we make to further the initiatives about clinical trial readiness for all Americans?
I want to end on a question from the audience. The healthcare world, you talk about all these advances, but the healthcare world, by and large, still uses faxes and printouts, and prescriptions have gone electronic by and large.
Yep.
But how do we move that into the future as well?
Yeah, so before I came to this organization, I worked in another part of government, the Health Resources and Services Organization, which some of you will recognize, and they do amazing work through their federally qualified health centers, through their resourcing of the rural health clinics, rural critical access hospitals, and so I know intimately that when we're talking over here in the pie of the sky, like everybody should use a generative AI-enabled patient care platform. That's fabulous. That maybe works over here at GW or works at Georgetown, MedStar, or wherever it works. But when you're out in the heartland and you're working in rural Iowa or you're working in southern Mississippi, that's not a reality of what they're integrating into clinical care workflows today. Part of what we're trying to do within ARPA-H is to go where people meet people where they are. Mm-hmm. And so we're also investing in technologies that are going to help support closing that gap. And so if we create, I loved what the Congresswoman was saying about mobile health units. If we were to create a capability that used advanced capabilities to help mobilize health, to help address maternal mortality or to address the opioid crisis or any of those sorts of things, it cannot just be this far, like this whiz-bang science project set of tools. It has to close the gap on how providers need to treat people where they live, work, and play across all of America. And so we're building those into the foundational tools. And you'll see that, like when you know, and I promise you, Val, when you look at some of the things that we're about to launch over the next 6 to 12 months, we are fully cognizant of needing to be able to help enable a provider, regardless of where they are, regardless of what type of clinical care facility they have, to be able to participate in the health innovations that others at Georgetown or GW are also participating in. So we're directly working to close those gaps.
Well, great discussion. Please thank Susan for joining us this morning. Thank you so much. I'll hand it back to Sarah. Thanks so much.
Thank
That was
you.
great.
Thank you, Dr. Susan Monares. All right, we have our first panel of the program, The New Old Age. More than 10,000 people turn 65 every day in the United States. As Americans are living longer and healthier lives, increasing life expectancies are also being met with declining birth rates. What are the social and economic consequences of an aging population? And how should the country's changing demographics inform policies and programs? Joining us in this discussion today are Ramsey Alowin, President and CEO of the National Council on Aging, Lindsay Milton Berger, Chief Advocacy Officer with the Society for Women's Health Research, and Melissa Batchelor from the George Washington University School of Nursing, Center for Aging, Health, and Humanities. She is also the host of the podcast, This is Getting Old. Welcome.
Thanks, Sarah. Let's go down the line and do kind of brief introductions, both on your organization and your kind of passion for this specific issue. And we'll start with you. Right.
Wonderful. Well, Bob, thanks for having us. At the National Council on Aging, for over 70 years, we've focused on improving the health and economic security of older adults. Through service delivery, helping older adults find jobs, gain access to programs that can help with food and medicine, navigate their chronic conditions, prevent falls, and gain access to life-saving vaccines. All that service delivery work we do with the tens of thousands of community-based organizations out there, that feeds our advocacy efforts. Yes. Oh. Can you hear me now?
Yeah.
At NCOA, we're deeply passionate about the issue of aging well. As a matter of fact, we believe aging well should be a right and not a privilege based upon your skin color, your gender, or even your zip code, like the Congresswoman raised earlier today.
Lindsay?
And I'm with the Society for Women's Health Research, or SWHR. SWHR is a more than 30-year-old national nonprofit, and it was founded by a group of women who saw these areas of need and opportunity in the women's health space. They noticed that there was a lack of OB/GYNs at the NIH. They noticed that women weren't being included in clinical trials, and they noticed that women's health and women's reproductive health was kind of an afterthought. And so they came together. They were integral in the passage of the 1993 Revitalization Act, which stood up the Office of Research on Women's Health and Statute, but it also required the inclusion of women and minorities in clinical research. Today, our mission is about promoting research on biological sex differences in disease and improving women's health through science, policy, and education. So we're really working to make sure that we're thinking about women in terms of a lifespan approach, and healthy aging as a key part of that. So often we think of women just in terms of what we call bikini medicine. It's about reproductive health, but it's so much more than that. And especially right now where we're seeing that women are sick and getting sicker, it's so important that we focus on improving health throughout the lifespan.
Melissa?
So Melissa Batchelor, Associate Professor in the School of Nursing at George Washington University, so I'm a nurse practitioner, and I've always worked in long-term care with older adults. At the Center for Aging, we've been doing a lot of work the past 4 to 5 years with 6 different age-friendly cities in Maryland, D.C., and Virginia. We put on an annual event called the Age-Friendly Ecosystem Summit, and it's really about bringing people together to talk about the solutions that we're going to need to care for an aging population. And so through that, started a weekly podcast called This Is Getting Old, Moving Towards an Age-Friendly World. And while I do talk about aging, ageism, age-friendly initiatives, it's really about all of these things that aren't in place for this population, and that's really what's getting old.
Speaking of your podcast, what have you learned from it, whether it's feedback or from actual real people?
Well, the content that actually gets the most traction is my work around Alzheimer's disease and helping family caregivers. And again, I think that there are so many different resources that people kind of get lost in trying to find and access information. And actually, when you go to YouTube and you type in Alzheimer's disease, a lot of the content that used to come up were kind of boring academic, like lecture PowerPoints. And so I think just having somebody having a conversation with them is really what they appreciate. And so it's kind of taking the science and the evidence-based work that we do and translating it for the public so that it's consumable to them. And they're looking on YouTube to find information. My demographic is 65 and older, mostly female. But YouTube is a search engine just like Google. And so most of the podcasts are titled around a question that people have. But it is a way to interact with people and let them ask questions and then give them an answer.
Because the internet's a great tool, but sometimes it can be overwhelming.
Right.
Especially for older people. I mean, my dad would not know how to get on YouTube. So does that focus them? Because you don't learn a lot of this caregiving in school.
Right, for like the regular person, I was like, we learned a lot about caregiving.
Yeah.
Like a lot of years of training for caregiving. But yes, the public doesn't. And the AARP has done a lot of work, around and the challenges that they are facing. They're being asked to do a lot of medical care, and most of the care that's happening now, even with Alzheimer's disease, is happening in the community. And so while there's a big focus on acute care, it's really home and community-based services is where this care is going to take place, and partnering with, and letting people know what an area agency on aging is. What is the National Council on Aging? Yes. Right, and so it's educating them to say there are resources. I think a lot of caregivers feel like they're isolated and they don't know what to do, so they are turning to the internet. And if they have somebody who's like, hey, here are federal resources, here are resources in your state, and here's what's what an age-friendly city looks like. Do you live in one? So it's just kind of sharing solutions.
Ramsey, you want to?
Oh, absolutely. I mean, it's overwhelming navigating all the complexities of aging. It's increasingly complicated as it relates to our health. It's increasingly costly. Older adults themselves can be overwhelmed. Caregivers can be overwhelmed, but you're not alone. Right. There are over 600 area agencies on aging. There are over 10,000 senior centers that we work with directly that are deeply rooted in communities that can help individuals navigate these chronic conditions. And chronic conditions are what are top of mind for us.
Sure.
Our research demonstrates 80% of older adults experience 2 or more chronic conditions. We've done some novel research using a new methodology with the University of Massachusetts Boston's Gerontology Institute, really looking at the true cost of those chronic conditions, the lost wages, the medical costs, the non-medical costs, and it's incredible. I mean, diabetes, hypertension, cancer, those are your most costly chronic conditions. And what you'll find is women and people of color experience those conditions disproportionately and, of course, have fewer resources to draw upon in order to afford them. Mm-hmm. And I'd love to just share a couple numbers because they're eye-popping. So for whites, cancer tops the list of chronic conditions as most costly. $252 billion a year in lost wages, medical costs, and non-medical treatment costs. For Blacks, it's diabetes and hypertension, and they come up at about $35 billion a year, respectively, in out-of-pocket costs and lost wages. And for Hispanics and Latinos, diabetes is the most costly, and our research demonstrates that's about $40 billion a year. And so we really need to look closely at the full range of interventions that can help individuals navigate those chronic conditions. And that's brought us on a journey, and I'd love to share more about that later.
Lindsay, you talked about disparity between women's research and men's research and landmark laws. I believe that you mentioned one in the 1990s, 93. Where are we on that? How does women's research compare to men's research now, and how far has it come, and what are the obstacles moving forward?
We've made a lot of strides in improving the representation of women in clinical trials, but we still have a long way to go. We particularly are seeing now, while more women are participating in clinical research than ever before, there are still efforts that need to be made to improve the representation of diverse populations of women in clinical trials. So racial and ethnic, different racial and ethnic groups, people in, rural versus urban areas, and importantly, the inclusion of pregnant and lactating populations in research and what that means. And then the other thing I'll flag is that there are really key areas where research has shown that women are still underrepresented in clinical trials, things like cardiovascular disease and mental health, and that's really unacceptable. So we've made progress, but we still have a long way to go.
Melissa, what concerns you the most? I mean, 10,000 people turn 65 every day in the United States. We have healthcare worker shortages now. The healthcare system is still trying to deal with COVID and supply drug shortages. But moving forward with an aging population, what's your biggest concern?
I think, well, the workforce is certainly an issue. We have about 1 million physicians in this country. Less than 6,500 are geriatricians. Out of 4 million nurses, like less than 2% are board certified in gerontology. So we have a workforce largely unprepared to care for older adults. And so the Age-Friendly Health Systems Initiative has helped try to move to geriatricize health systems instead of trying to create individual providers. I think the biggest thing is, like, when we talk about aging, right now most people think we're talking about the boomers, and that's where that 10,000 a day number
Right.
comes from. But actually, about 3 years ago, the millennials took over as the largest generation. So the boomers aren't the largest generation, and the millennials started turning 40 a couple of years ago, which makes them old enough to sue for age discrimination in the workplace. So my mission is, like, we have 25 years to get ready for the millennials for the things that older adults of today need. And so it needs to be a conversation about us. It's, we are all aging. I've always taught gerontology to nursing students, and I've never really had one run in the classroom and be like, I want to work with older adults. I want to work in a nursing home. They don't, but it's like, if you work in an emergency room, if you work in mother baby, by default, you are a geriatric nurse, because there'll be a grandmother that wants to come in to hold that baby. You're going to have to know how to interact with that person. 60% of our hospital beds are filled with older adults. So I think it needs to be a conversation about us and not about them, because we're all aging. And one of my jokes is that I would take care of someone who's like 80 years old, and they'd be like, well, I eat in this dining room because the old people eat in that dining room. And I'm like, well, how old are they? I mean, older adults are anybody 10 to 15 years older than ourselves.
Right.
So it really is about all of us, because we're all aging, and it's actually ageism is the only ism that's kind of absent from the national conversation about DEI. But it's the only inclusive one, too. It's the only one that we're all doing. But our thoughts about aging actually predict our health. So if we have self-imposed ageist beliefs, we actually have poor health outcomes because of it. So what we think about aging actually matters a lot.
Right, and with aging, as you mentioned, everyone is aging, and it's come up obviously in a political sense. It mentioned in the debate last night about age of politicians, and when an athlete is struggling, the media will call him aging or her aging. But if they're doing well, they're not aging. So, and as David Axelrod said, age only goes in one direction, unless you're Benjamin Button. Lindsay, what about the stigma of aging? Has that improved? We've seen, I think, the stigma of mental health during COVID improve, not fully, but certainly more people tackling it. And now as people get older, and that did take a bit of a blow during COVID because the population average age expectancy went down. But where do you think we are with that?
I think stigma is improving, but again, there's work to be done. I think that's going to be probably a common theme here. I think even whenever we talk about things like menopause, you know, I've been really heartened to see, you know, people come on both sides of the aisle increasingly talking about menopause in recent weeks and recent months. But there's definitely still a stigma when it comes to talking about menopause in the workplace. The society is currently analyzing some results from a survey that we just put into the field, you know, trying to learn from people about the workplace experience when it comes to menopause. And, you know, as part of that, we're learning that people are kind of uncomfortable talking to employers about menopause. Similarly, employers don't know how to talk to their employees about menopause. So how can we kind of encourage things like, you know, workplace policies within organizations to make those conversations easier? I think the more that we take steps like that, the more that we can break down stigma and the greater we can advance this conversation.
Ramsey, you've made the case, which is the sound one, of course, but I want you to talk about a little bit more that financial health equals physical health. You don't have the financial health,
That's right.
It's tough to get the physical health.
Absolutely. I mean, we see it every day with the millions of older adults that raise their hand for help and come to the National Council on Aging or the vast number of community-based organizations we're working with. Your health can determine your wealth, and your wealth can determine your health in the United States of America. And in our deep commitment to ensure aging well is a right and not a privilege, we're really trying to unpackage that and look at some of those drivers, some of those social determinants that end up having implications for our life expectancy ultimately. The disparities are significant in the United States, and while some enjoy the gift of additional years, we've still not yet cracked the nut on the quality of those years. And so that's why we commissioned this research around the cost of chronic conditions, because they are such a driver. And in going on this journey, in addition to doing the research, we got out there into communities. We held town halls across the country at senior centers, in states, in communities, and really heard from people directly about their challenges. And the reality is, when Social Security is not enough and they're making tough decisions between medication and foods and exercise, that comes into play in terms of their health outcomes. We literally heard folks sharing with us their struggles around navigating hypertension and diabetes and the chronic conditions that exacerbate all the rest, obesity, and their frustration of not feeling seen and not having access to the full range of interventions related to obesity. And so that was an issue that bubbled up to the top for us. We literally heard people saying they felt invisible when talking with their doctors about various interventions, that they live sick and then die. They live sick and they live in extraordinary circumstances, struggling, and don't feel seen and heard, and ultimately die if they don't get the right supports. That brought us to a bubbling point, to a tipping point, if you will. And we realized we need an obesity bill of rights. And so that's something we'll launch in January with the National Consumer League together to really get out there and talk about the importance of evidence-based health prevention, evidence-based health promotion and disease prevention interventions, and the full range of interventions related to obesity specifically, given the interplay between health and wealth.
How did that idea come about? How long was it kind of percolating?
Well, it was really organic, going out there, hearing from older adults themselves, and finding them deeply engaged. You know, you'd think that this was a topic that was particularly sensitive, but it came up organically, talking about chronic conditions and some of the drivers and some of the challenges, especially as individuals were seeing that there are new solutions, pharmacological interventions that can actually help, that private insurance covers, that the VA TRICARE covers, but Medicare beneficiaries can't gain access to. And that felt unjust, that we are missing a piece of the puzzle here.
Lindsay, as far as a magic wand, if you had policymakers or maybe something that's working that should be highlighted, what are the solutions so that we have good quality of life over the next decade or two?
What I would really love to see, and I think that it's something that's feasible, is greater coordination across the federal government about what they're doing in women's health. So let's bring together the National Institutes of Health, everything under HHS, HRSA, FDA, CMS, but then also bring in the Department of Defense and the VA, who are conducting really, really impactful research, and come together in a coordinated way, have those agencies, share their findings, have public meetings so that people can be aware of what they're doing and come up with solutions that way.
Melissa, same question to you.
You said the magic wand.
Yeah, what do you think policymakers
ADD,
should do? Like, what is the most important thing that they should
I know what I was
focus
thinking,
on?
because I was thinking a lot while you were talking about women's health, particularly because most women are caregivers. They're the backbone of our, of the care that's being delivered in the home and in our communities. And so I think having, and there are some legislative efforts right now in Congress to help caregivers, but just like employee assistance programs, talking about menopause, it's also how do you, care for children and aging parents, so I think there just needs to be more support for caregivers of people living with chronic illness, but also there needs to be a lot more focus on health promotion. Like right now we have a sickness-based healthcare system, and I think nurses, it's a great opportunity for us to really kind of step up and to try to help people to prevent chronic illness. It's not that's not normal aging, although it's common. And so it's changing those perceptions and trying to get people to make lifestyle choices that prevent chronic illness.
Go ahead.
Well, and to that point, expanding Medicare coverage to be able to provide access to evidence-based health promotion and disease prevention programs in non-clinical settings. So many community-based organizations administer programs that we know work, but Medicare doesn't cover it. And they're not in a clinical setting. So we need to close the loop on that.
How, and this is for anybody who knows or has studied it, but what could we learn from other countries internationally? The United States is very focused on the United States, but are there, obviously everyone has their own health system, but has anyone seen something where that's something smart that maybe U.S. policymakers should do?
That's interesting. I mean, I can take it from kind of a menopause angle. So we hosted an event recently with a couple of members of the United Kingdom's House of Commons Women and Equalities Committee about their efforts on menopause. In July of 2022, they released a report about menopause in the workplace. And they provided a set of recommendations to their government about things that could be done. They intentionally were not very prescriptive, but they made recommendations. Let's try things like a menopausal leave, and try it with one sector that's predominantly women and see how it works. Hire somebody at the federal level to focus specifically on menopause in the workplace. Come up with a template that workplaces can utilize to help women that are navigating this transition. And so there may be some interesting things for U.S. policymakers to take from reports like that. I think, it's always important to look at other countries and see what they're doing and see how we might be able to learn so we don't have to necessarily reinvent the wheel. But that's one area where we might be able to take some lessons learned.
Melissa, regarding mental health in particular, which does affect older Americans disproportionately, what do you see, how did COVID affect older Americans? I think the audience and people watching all know that a lot of people suffered during COVID, and what was the impact of that on mental health of aging Americans?
Yeah, I think COVID definitely probably shed some light for all Americans about the impact of social isolation and loneliness.
Right.
So with a broader understanding from like a population health perspective, I just hope that people don't forget the impact that social isolation and loneliness can have on the mental health of everyone. And, for our communities to try to pull together, to help one another. Like I lived up here in D.C. for about 8 years, but I moved back home to North Carolina about in February of this year. And I was like, everybody here is so nice. Like
in North Carolina,
like
right?
everybody in the elevator up there, like, hey, and I'm like, okay, wow, I had not even realized like how that was is a different culture here.
Right.
But how do we get people to interact with one another and for communities to kind of come together to help one another? Like the Village is another neighbors helping neighbors type model, where people support each other, whether it's transportation or getting to the doctor. So I think we just need to focus more about how to pull communities together and pull people out of their homes to interact with one another, particularly intergenerational activities and housing.
Because it's so lethal. I mean, social isolation for older adults, it's like smoking a pack of cigarettes a day. It's that lethal. And with the social distancing required due to the pandemic, I think there's a lot we have to unwind to get people feeling safe and comfortable to come back again. And those relevant community-based organizations can be great vehicles for that. Every day, over 1 million older adults go through the doors or log on to a senior center to engage in programming. And increasingly, those are becoming gathering places for different generations as well. Adult day health co-locating with daycare facilities. So when the Surgeon General comes out and talks about the lethal nature of social isolation, I think it's really an opportunity for all of us to reflect on intentionality in terms of bringing each other back to connect and how that really is essential for our public health as well.
Lindsay, I want to end on a positive note. What are you positive about, whether it's trends or treatments going forward, where there are a lot of problems we've discussed. COVID obviously set the world back years in many ways. But what's a positive aspect that you've seen progress and hopefully that will continue?
The thing that I am most excited about going into 2024 is last month the White House announced the White House Initiative on Women's Health Research. So this is about prioritizing and elevating women's health at the federal level. It's about understanding where we're funding how we're funding research, where we're funding research, and then where there are gaps and opportunities. So they're going to bring these agencies together, hear from them directly about what's happening right now. They're going to, hopefully listen to stakeholders from the public and private sectors about where there are needs and opportunities. And I hope that the recommendations moving forward will represent a paradigm shift in women's health in this country. So it's not seen as a niche market when women are, in fact, 51% of the population, and should be seen as such.
Absolutely. We're running out of time. Please thank our panel for joining us this morning. I hand it back to Sarah.
Thank you, Bob.
Thank you again to our panelists. And now for a word from our sponsor, CVS Health. We are going to show a short video, and then we will be joined on stage by Marissa Rogers, Executive Medical Director of Oak Street Health, in conversation with Joe Ruffalo, the SVP and General Manager of The Hill.
Oak Street Health is celebrating 10 years of helping older adults live healthier lives. Our innovative care model has reduced hospital admissions and emergency department visits among older adults by more than 50%. Every center we open is an investment in the health of our patients as well as the local community, serving as a hub for activities, events, and educational workshops. In just 10 years, we've gone from providing care for a small group of patients to saving lives and improving the health of over 250,000 older adults. And by the end of the year, we will have grown from a single center in Chicago to over 200 centers in 25 states. Everyone deserves great health care, and that's why we're rebuilding healthcare as it should be.
That's great. Well, Dr. Rogers, thank you so much for being here today. We just heard a lot about the future of aging. People are living longer. We hope they are living healthier as well. Oak Street has been focused on this idea for quite some time. Can you tell us a little more about the model itself?
Absolutely. So we are a national organization that provides comprehensive primary care for seniors. We're in 25 states. It's really interesting. We just opened our 200th center on Tuesday, which is really exciting for us. So I think the panel below really talked about a lot of the challenges of caring for senior populations, the social and medical factors. Our model is designed to address all of that. So we really do three things very differently. One is much more time with patients. Two is robust care teams. And three is being very proactive around engagement with patients, outreach externally outside of the office. So, for example, our providers have a much smaller panel size than in traditional primary care. Our providers, which consist of physicians and nurse practitioners, have about 500 patients to manage, which is about a quarter of what you see in fee-for-service medicine. So we're able to see our patients much more frequently and much more in depth and get to know them and build that trust and relationship, which is really critically important. We also recognize it's not just about medical care. We really do have to address the social determinants of health, be that transportation, food insecurity, social isolation. So we do screen for those things, as well as have social workers on site at every location, behavioral health specialists, and community health workers to really comprehensively address not just medical problems, but social and economic barriers to care as well.
Excellent. What does VBC or value-based care mean at Oak Street? Have you seen lower cost and better outcomes? And how does the integration with CVS Health impact that?
Yeah, so value-based care, as you know, can mean a wide variety of things. For us, it's a full risk model. So we are accountable for the care that's provided inside our centers, but also the care that's provided outside, whether that's emergency rooms, hospital visits, or specialty care. So we really want to manage primary care as proactively as possible to decrease those downstream outcomes. So we're able to get the full risk model allows us much more resources to put into primary care. So we, on average, put 2 to 3 times more resources than traditional primary care, and we're able to do that because of the value-based care model. The outcomes we've seen are decreased in admissions by 50%, decrease in ED visits by 50%, and readmissions by 40% compared to the Medicare benchmark. The CVS relationship really is about helping us grow. So I mentioned that we reached 200 on Tuesday. Next year, we'll open 50 to 60 more centers. So it really allows us to expand our model to communities that need it. Our model is a model where we are mostly in low-income communities. Almost 50% of our patients are dual eligible for Medicare and Medicaid. So we're talking about a high-risk population with, on average, 4 to 5 chronic diseases, and about half of our patients do have a behavioral health diagnosis.
What are the biggest challenges in terms of providing primary care for aging populations?
I think the challenges are many of the things. That panel before was a really nice tee-up around the challenges. I think specifically because many of our patients are low income, it's not really just about the medical care itself, it's about all of the other factors. So we're very intentional, certainly about screening and diagnosing and treating medical conditions as aggressively and early as possible to decrease complications. But we are equally aggressive around screening around social determinants and determining solutions, whether that's partnering with our social work to help identify benefit opportunities, whether that's having our community health worker connect with resources in the community such as senior centers. All of our centers, and I think that clip where patients may have been dancing, all of our centers do have community rooms in them. So we actually have activities for seniors to combat social isolation. I think that was a great call out previously around the impact on morbidity and mortality that we saw with COVID because of that. We want our patients to be able to have safe places to come in, do Tai Chi, do yoga, listen to music, whatever the community is interested in. We have a group of folks who put on activities, and sometimes those are a part of my prescriptions for patients, not just medications, but I'll get out the calendar of events and we'll go through it and circle which ones, which is really about helping them be well and engaged, which we know is critical for healthy aging.
Very nice. You talked a little bit about behavioral health care, and obviously that has a huge impact, particularly on seniors. What are you doing at Oak Street around that?
Yes. So we screen routinely for depression, which we know is the most common behavioral health disorder in our population. We want to be able to detect it as early as possible. On site, we have behavioral health specialists who are licensed clinical social workers who can engage in one-on-one therapeutic relationships. We also have psychiatric providers who provide extra telehealth support and can do complex diagnosis, medication management, and help us partner to really advance and treat behavioral disease.
There are several chronic health conditions impacting seniors as well. How do you approach their needs?
Yes, so what we are seeing in our patient population is a lot of the risk factors that lead to cardiovascular disease. So a lot of hypertension, a lot of diabetes, a lot of chronic kidney disease. What we are doing is being very aggressive about screening and treatment. We have diabetic protocols where we partner with our nurses who are all trained in diabetic education. For our patients that are high risk, we also use pharmacy partnerships and our PharmDs to help do medication management and telephonically. So we are very proactive about managing chronic disease and trying to get it to control before it becomes complicated. I'll leave it there.
Yeah. Well, as you look at the health system over the next few years, what are you optimistic about?
Well, I'm optimistic about the trend towards more value-based care. I do think we know that we spend a lot of dollars on healthcare in our country, and we don't get the outcomes that those dollars often that we should from those dollars. I also think that models like ours highlight the need for more spending in primary care. Most of the healthcare dollars are unfortunately treating complications and addressing specialty care as opposed to primary care. I think models like ours have shown that if you invest in primary care, you can actually bend the cost curve and decrease the things that are main drivers of the healthcare system, like hospitalization. So I'm excited about that transition. For Oak Street as well, I'm excited about our continued growth. I think that our model has been very well received amongst patients and the communities we're in, and so we're really excited to continue to spread to more communities.
Awesome. Well, Dr. Rogers, thank you so much for your time today.
Great, thank you.
Thank you.
Thank you again to our sponsors at CVS Health. Next, please join me in welcoming back Bob Cusack, Editor-in-Chief for The Hill, in a discussion with Congressman Vern Buchanan of Florida, Vice Chair of the House Ways and Means Committee and Chairman of the Subcommittee on Health. Thank you for joining us today.
Thank you. Thank you, Congressman, for joining us. You're now regular at our event. You headlined our event on Alzheimer's earlier this year. I want to start on that issue. You have bipartisan legislation that we talked about it in the green room that just moved through the Energy and Commerce Committee on voice vote. Tell us a little bit about the bill and what its path moving forward now that it's cleared the Energy and Commerce Committee.
It's the Merit Act.
Yep.
My bill got passed out yesterday. So our goal is to basically give access to people, in terms of potential Alzheimer's in early stages. I think there's 2 or 3 drugs that are out there now that see a lot of promise, but everybody's concerned about who's going to pay for it. So this is what this bill does: is make sure people get that. As I shared with you before, my father, so I'm a little more sensitive about that. I took care of him for 10 years. He had Alzheimer's, and it's a brutal process for families and everybody else that's involved. And, drugs like this might have made the difference if you get them in the early stages. And they came out with an initial drug, and then that was showed so much promise, 22%. But now they're moving up 35%, and then someone at 60%. That could make a difference if you catch it early. And that's true of a lot of things, cancers and other things, if you get them done early. And that's where I think we're going. That's the exciting part of the promise moving forward.
What is the future? Are you looking to attach this either to a foreign policy bill that's being debated now, or perhaps to the government funding bill early next year, or to potentially move it on its own?
We're going to look at all the options,
Okay.
all the above, and get it out as soon as we can. So, that's our goal, but I've got a good working relationship with the new speaker, and of course, the person that controls the floor is a good friend of mine, Steve, so I'll be talking to them. I wanted to get this passed out at E&C yesterday.
You're a leader in the House, and obviously the House Republicans have had, an interesting Congress, let's put it that way. This week, Patrick McHenry announced his resignation. Kevin McCarthy is leaving Congress at the end of this month. The majority is getting small. What's the mood in the House Republican Conference right now?
I think people realize we're going to have more challenges. It's been difficult. It'll make it more challenging, but not impossible. Obviously, everybody's got to realize for anything to get done, if you end up with a 1 or 2 member majority, you've got to, kind of either hang together or hang separate.
Yeah.
So the goal is we got to find a way to work together and try to get some things done. And people that know me, I'm very bipartisan.
Yeah.
So there's some opportunities to do some things together. I think that's the way the government would, is put together originally, and and maybe that's being 30 years in business, having a lot of employees. That's really what my focus has always been, is try to find people on the other side. We've got a lot of things passed over the years, but the way we get them done is work with the Democrats on the other side where it makes good sense.
That 3-week stretch without a speaker, there were a lot of predictions, bad ones, including some made by me, what would happen next, because we had never seen this. It was unprecedented. Do you feel like House Republicans are now behind the new Speaker Johnson, and they will be, by and large, the rest of the Congress, so we don't see that again sometime next year?
Yeah, I think that, frankly, to be candid about it, he was the only one that could get the votes.
Right.
221. There might have been some others, but I mean, in terms of the people that threw their hat into it, I know him personally. He was in Florida. We did an event together and stuff like that just recently. So I think he's a very honorable guy. He's very likable. He's a very smart constitutional lawyer. There's always something someone doesn't like or not.
Sure.
But I think he's the right person at the right time. And I'm hoping that, like I said earlier, the only way I see things getting done much is working together. And I always tell my Democratic friends, hey, we're all Americans. Let's find a way to get to yes.
Your panel on health and the Ways and Means Committee, what's the agenda for 2024? What are you looking at?
Well, I think that, I'll take this. I was looking at the statistics, but I'm really focused on preventative care. They set up a task force, Healthy Futures. Yep. When you look at the data, we're spending $4.3 trillion on health care, 13,000 per person. And we're getting, I think, less. People are getting sicker. Obesity rate, 55 or 50 and above, at 40%. Even teenagers from 13 to 21 or 22 is at 22%, the obesity rate. That's double what it was 10 years ago. So I really think, I tell people, my sense is you got to be the CEO of your own health and take the initiative. And we've got to do more about educating people. And it's not just that people don't care. It's very difficult because so much of our food is so over-processed, in my own opinion. And so I really try to promote the idea of eating, a better diet, trying to be more focused on fruits and vegetables. And then I think the idea is someone could start walking 2 miles a day, 5 days a week. It'll make a huge difference. I have a doctor friend of mine that told me he works with a lot of patients that come down from up north down to Florida, and he's got a private practice. And he says they come in, there's 70, 80, a lot of them, they're on 6, 7 different pills.
Right.
And he said, you want to get off a lot of that? And he said, well, I can't get off that, doc. He said, no, you want to get off of it? I said, what are you talking about? He said, I want you to start walking 2 miles a day, 5 days a week, and in 30 days, I'll take you off half of what you're on. And so
and it works.
whether that's exaggerated or not, that was his experience. And I think that's the mindset we have to, we've got to educate and challenge people to take on more responsibility themselves, because we don't have enough money. We're spending 20% of what we take in the economy just in terms of health care in a given year. The other thing is, I'll just say quickly, is you've got to be much more proactive in terms of health care and try to prevent things from happening. I had one guy tell me many years ago, and it stuck with me, is he said that 50% of people that have their first heart attack, now maybe that number's not the number today, but that was a number I was told many years ago. Because my brother, a year younger than me, had a stent put in, and he said 50% of people who have their first heart attack don't see the next day. So I know myself, when I heard that, I said, I don't want to tell you, but Ken Cooper a long time ago, but I said, well, is that the case? He says, yeah, maybe it's not quite there, but it's in that ballpark. But the idea I walked away with, I don't want that to happen in the first place, for me or anybody else. And I think we've got to, take this a lot more serious in terms of our lifestyles and what we're trying to do.
How do we do that? How does the government do that to make the healthcare system less reactionary? What do you think policymakers or the administration, whether it's this administration or the next one, should be really educating people on? Is it a national? Maybe some of this was tackled in the task force that you mentioned.
Yeah, I just think that we've got to do what we can to get the message out there more. I want to do a lot more hearings in terms of a lot of this, and And the numbers are just so staggering to me in terms of the obesity rate, in terms of even the military. They say 22% or 30% can't qualify physically. I went in as an 18-year-old, and that's pretty, in terms of readiness and our armed services, that's pretty staggering. So I think we've just got to work more with our doctors, set up the proper incentives. We're spending enough money, like I said, $4.3 trillion. Let's put more into challenging people, educating people, create the right incentives, maybe for, join a health club or something like that. But there's things that we can do policy-wise. There are various bills out there. But whatever we can do to get people thinking about it, not everybody will, but some will. But that some might make a big difference in terms of going forward. I'm very, very concerned about kids, especially younger kids, and you see it in the playgrounds and stuff where kids are just not getting enough physical exercise, or many times they're eating a lot of the wrong things or sugary drinks. Now, I'm not totally against that. I always tell people 80-20, but the point is that, we just got to be more sensitive. We have 9 grandkids now, and the wives are very careful about, what they eat and how much they eat, because a lot of our food, as I mentioned earlier, is heavily processed. You're not eating food, and that's why it's the fault of a lot of people, because they don't realize what they're eating, which is no nutritional value. I had put on some weight, you're on the yo-yo diets, you're up and down and everything. I finally read a book that made a lot of sense to me like 15 years ago, and I was able to maintain my weight finally. And it was an equation. The guy wrote the book, and on the top of the equation is nutritional value of the food that you're eating. And he rated every types of food that you would eat in a given day, and underneath it was calories. And so I kind of took that a little bit as a religion.
Right.
Not, I get back to the 80-20 idea, but just being more careful about what I'm eating. But the most nutritional food with the fewest calories. And then there's got a whole book that lists every single thing. So again, it gets back to leafy greens and fruits. You can have some other things and stuff like that. But just to try to change it and modify your diet a little bit, and then get active physically, like riding bikes, do that. Do what you enjoy doing, but get out in the fresh air and do some things.
What about the long term? And I know neither party is going to be doing anything in 2024, but we do have Medicare headed for insolvency. You mentioned your 9 grandkids. At some point, policymakers are going to have to get together to come up with some reforms that extend the program. You're a bipartisan legislator. We're in divided government, but we're in very polarizing times. Do you think that Congress, or even a future Congress in the near term, can tackle such a big issue?
I'd like to think we can. It's not just, in terms of insurance and Medicare. It's also Social Security.
Right.
One's viable. They're claiming to 4 to 6 years Medicare, and then you look at Social Security. Maybe that's 10 or 12 years. But we need to be dealing with both of those. And I talked to one of the leaders on the Democratic side, and he said, Vern, we've got to get in the boat together, blame each other, but get it done.
Right.
And I think that's the mindset. We've got to find people that are courageous enough to start dealing with it, because they're both going broke, especially Medicare as you look at where this is going if we don't turn this around. That's why I'm so concerned about just the general health. And I didn't mention that, but we're spending the most, $13,000 per person, and we're getting the least in terms of performance with everybody. So both those are very important. They're the right thing. I'm in a district like Sarasota in the western part of Florida. I can just tell you, we have a lot of seniors, a 5th oldest district, and many people, that's all they have. Not all of them. A lot of them have been lucky or got some other funds, but many of them that turn 65, all they've got is their Social Security and Medicare. And I'd see that on telephone calls and everything else. It's really tragic and sad, but that if you didn't have that, it'd be really a disaster. So,
over the years, a lot of lawmakers have expressed some frustration with the Congressional Budget Office because, to your point of preventive, very important, but sometimes the scoring doesn't give credit for the prevention. Has that changed in recent years, and have you pressed CBO to come up with, hey, there's more savings here, but if you don't give it to us, it's going to be hard for us to pass this bill?
Yeah, well, we haven't done as much as we want in terms of scoring because it becomes politicized.
Right.
And as soon as you go down that road, but, I'm ready with I think there's some Democratic members, ideally. we really need to put together a group of us and start working on this. And the time is right now, not tomorrow, not next year or 2 years from now. I know it's going to be a challenging year this next year just because we're basically, we got a couple extra members, but that's not much.
No.
So that's it's going to be a challenge. But I'm still hopeful. I look at things maybe different. I'm an optimist, and I still think we've got a lot of challenges, but we're still the best place on the planet.
You have another bill on home infusion that would allow patients to receive medications in their home.
Yeah.
Where's that bill right now?
Well, I like to think we can get something done the first part of the year. It's bipartisan, but I can tell you in our area, our region, and it's all over Florida, but the country, a lot of people would like to have that opportunity to do it in their homes. And that's why we're pushing it. It's a bill that, I wasn't, thinking about as much, but it got brought to my attention by a lot of our seniors in the area, and then we were able to work with some other members. So I feel pretty optimistic. I think it's a bipartisan bill. We'll get something done. And that's how I get things done. I've got 30-some initiatives. You have some people who never got anything done that I've got passed because they know I'm kind of a go-to guy in terms of if it makes sense. Someone brings me something, my mindset is see if we can't get the yes. We can't on everything, but a lot of times we can.
And is that the genesis of a lot of your bills, just from what constituents say, like, hey, there's a problem, I can't get this at home?
Yeah.
And then that leads to you talking to Democrats and getting a bipartisan bill?
Yeah, I like doing a lot of town halls.
Right.
I don't do as many as I did, but I like doing a lot of them because of COVID and everything. But then we did telephone town halls. But the thought is, I've always felt like I never was in politics before. I was in business for 30 years, but I always felt nobody listens in Washington. So the thought is I try to go out of my way and get their thoughts and their opinion. And a lot of the things that we got passed is because of their bringing me different ideas that made sense in our area. Then we talked to other members, same thing in their area, and then all of a sudden we got something we can get done.
Yeah, those kind of bills don't get the attention, but there is bipartisan legislation out there.
And that's exactly it. I mean, there are things that get done, but if you do them quietly and just get them done, you don't
That's
get
the
the
best way to
attention.
do it. Yeah, exactly. Well, we've run out of time. Please thank the Congressman for joining us.
Yeah.
And I hand it back to Sarah. Hey, thanks, Congressman.
Thank you.
Always good stuff.
Good seeing you. Thanks.
And we will now turn our attention to the subject of cancer. Please welcome Dr. Danielle Carnival, Deputy Assistant to the President for the Cancer Moonshot and Deputy Director for Health Outcomes at the Office of Science and Technology Policy at the White House. Welcome.
Thank you.
Well, thanks for joining us, Danielle. So, big question, and let me tee it up. Where are we on Cancer Moonshot progress, and what are the biggest challenges moving ahead?
Yeah, so that's a big question. How much
It
time
is.
do we have?
15 minutes.
All right. I think, so as you know, Cancer Moonshot started back in 2016, but the President and First Lady reignited it almost 2 years ago now as part of this administration and set new goals to reduce the death rate from cancer by at least 50% over the next 25 years. That means saving 4 million people who otherwise would die of cancer by 2047, based on current trends, and to improve the experience. So we've made a lot of effort across both of those.
When you say improve the experience, I just want to stop you. What do you mean by that?
Yeah. So we know that people get a cancer diagnosis and are faced with lots of decisions. They're faced with financial toxicity, they're faced with loss of job, they're faced with caregiving challenges, and so how do we make sure that we're not just saving and extending lives, but making sure that people are treated as humans through this process, and that we have as many tools in place to help them survive and thrive through their treatment. And so we've taken a lot of steps that we know will make an impact on both of those. A big one we were just talking about is making sure that cancer navigation services are reimbursed for as many people facing cancer as possible. This means you have someone with you making those decisions, talking about clinical trials, referring you to additional support services. ARPA-H, a brand new agency to drive innovation in new ways to prevent, detect, and treat cancer and other diseases, has invested nearly $500 million already. A lot of that is going to impact the fight against cancer. The one other thing I'll mention is this is not just about driving new ways to prevent, detect, and treat cancer, which we need. It's making sure that the tools we have today and those we develop along the way reach more Americans. And so we've been focused on cancer screening and making sure that that access is really reaching across the country. We've been focused on prevention through implementation of the bipartisan infrastructure law that's cleaning up toxic sites and water lines, and on making sure that smoking cessation services reach as many people as possible. A lot of the gains that we've seen, if you look quantitatively over the last few decades, has been driven by prevention, and especially by a decrease in smoking. And yet smoking is still the largest single driver of cancer death in this country. And so we have more to do.
And you mentioned access. How do you ensure equal access, which is very hard to do?
It is. I think the first step, and one that the president has been a huge supporter of for decades, is making sure that as many people as possible, as many Americans as possible, have access to health care coverage. And so we've continued that push, we've continued that fight. The other thing is making sure that the services and the tools that are available are really reaching into communities. For example, the Centers for Disease Control and Prevention, CDC, as part of the Cancer Moonshot, made a more than $1 billion commitment around cancer screening. They've already put out hundreds of millions of dollars of those grants. Those go to community organizations and local providers that have that reach into communities. The other place we've done that is through HRSA, part of HHS that works with the federally qualified health centers that serve some of the most underserved and low-income parts of this country. And they also have been doing a lot of work on outreach, on cancer screening, and they've partnered with some of the best cancer centers in the country through the NCI Comprehensive Cancer Center Network, so that when someone, screening is really important, but getting someone through to diagnosis and appropriate care is the rest of the pieces of that puzzle. And so now the federally qualified health centers are partnered with those cancer centers, and people have a pipeline to receive good care.
Well, let's talk about innovation, because you get to see behind the curtain, right, of what's coming. Mm-hmm. What is coming, and what are you excited about?
Oh, that, the good news is that there's a lot to be excited about.
Okay.
I think from the original investment from the Cancer Moonshot in 2016, where in a bipartisan way, we received $1.8 billion
Yep.
over 7 years for the Cancer Moonshot through the National Cancer Institute. We are seeing the outcomes of some of that work already in understanding what's driving pediatric cancers, in understanding more around brain cancers, which has been such a challenge for many reasons. As a neuroscientist, I understand some of them, but have been such a challenge for many reasons. And now we've seen ARPA-H come in, and ARPA-H is meant to be an additional tool in the biomedical research toolbox to look at problems in a different way, to really pay for success and delivery and drive innovation through making sure that we're not just delivering a new tool, but that it is actually reaching people. So they've set up this network across the country. But I think what I'm excited about is we, more than ever, are seeing an understanding of risk that is going to get us to earlier diagnosis. And we know that earlier diagnosis improves outcomes. And so while immunotherapy and targeted genetic treatments for some cancers have shown a huge impact on changing outcomes for people facing a cancer diagnosis, what's going to get us to our goal is really getting more people an early diagnosis when we have tools that can get them back to their lives.
We live in an age of misinformation, and that is especially true in healthcare. How does the government deal with that, or how do you deal with that to make sure that people aren't scammed or their health is harmed?
Yeah.
What's the administration doing on that kind of stuff?
Yeah, it's a big challenge. I think it may be oversimplifying it, but to go back to the relationship between a physician and a patient, right? Like that's where people are trusting the information that they're getting. That's where they're making their decisions. And I think keeping that trust relationship is a responsibility of all of us, and something that we're paying a lot of attention to. The other thing that may not be an answer that's expected is there are lots of risks with artificial intelligence, and,
Right.
and we're working really hard on making sure that we're mitigating those risks. But there's also a lot of opportunities. And one of the opportunities that I think is going to make a huge impact in healthcare is the ability for people to get targeted information in a language or in a culturally appropriate way that they can receive and act on. And so as we build these AI systems, it's not good enough just not to introduce new bias through AI, which is a huge concern, but to use AI in healthcare to really improve equity, improve the ability for people to get the information and knowledge that they need to make preventative healthcare decisions, to get access to early screening and detection, and to make decisions throughout their health journey.
You mentioned that this cancer initiative was a bipartisan effort in Congress, and I remember it was moving through, and it was touch and go whether it would get through. And then, legislation passes, and it kind of fades from the headlines. But the implementation is a big deal for government agencies. And I know that was a while back, and you said that we're already seeing good outcomes from that legislation, but it does take years. How do you coordinate with all the different myriad of health agencies? How does that work behind the curtain?
Yeah, so in 2016, there was a lot of work done to set that up, and I think that's one of the reasons that the Cures Act, that bipartisan members of Congress came together, because the entire community came together and set out priorities for what should be done. And federal agencies, NCI, because they got a large amount of funding, and that of course saw that through. But the Oncology Center of Excellence at the Food and Drug Administration, the FDA, was created in that legislation. There was a lot of work done through HHS, through the Office of the National Coordinator for Health IT, on making sure people have access to their own health information and that health information is more interoperable so we can learn from the experiences of more people. So we did a lot of work in 2016 to make sure that that work was followed through. And then we picked it back up in 2022 when we reignited the cancer moonshot. And the president created the first ever cancer cabinet. So this is what brings across government together, everyone from the Environmental Protection Agency and the U.S. Department of Agriculture to, of course, Health and Human Services and many of its components that have an impact here, Department of Veterans Affairs and Defense, Energy. I'll stop, but I could keep going. And the goal is, a lot of work is being done across the priorities that we have on screening, on preventing cancer, on understanding and addressing environmental and toxic exposure, on driving innovation to reach people in communities, and on better supporting patients and caregivers. A lot of that's being done in each agency, but what we've seen is that by bringing together, we can figure out, ARPA-H is launching a new hub and spoke model that reaches across the country, and we're going to have clinical trials reaching people in communities that were beyond the reach really of the research system prior.
Right.
But those are also going to be run at VA and DoD, right?
Okay.
So by having those conversations, we can make those connections and make sure we're learning from other parts of government and implementing across so that we reach as many people as possible.
I know the administration you mentioned has bold goals on cancer. But long term, can we really end cancer as we know it? And how long, what do you think that's going to take?
Yeah, I mean, the way we've defined it, it's changing how we know cancer today. So it's not just about driving cures or treatments that can get people back to their lives and turn a cancer diagnosis into a chronic illness that they can manage. It's about making sure we prevent more cancers, we detect them early. And I think we can do that. I think there has been huge bipartisan support for these goals for decades, and I don't think that that's going to stop. Cancer is a priority for this administration because it impacts every American family. It's a personal mission for the President and the First Lady because it has impacted their family significantly. Yep. It's impacted mine, and I think it's something that we can all get behind and show when we do come together, like the President said as part of his unity agenda, when we come together, we can solve problems for the American people and deliver.
And do you think, as a last question, we have made significant progress? Because we have, in a lot of ways.
Yeah, I mean, like I referred to a little bit at the beginning, we have seen the death rate from cancer, that measure, one of the measures of our success for the cancer moonshot, come down by about 25% over the last 2 decades. If you look even back further, it's been about a third of a decrease decrease in that cancer death rate. That is huge progress. That is millions of people getting to sit at the dinner table for Christmas, and being at the wedding that they didn't think that they were going to be at. And with additional progress in these areas that we've set priorities in, we need to double that rate and bring it down over the next 25 years by 50%, and if it is possible.
How can Congress help you?
Congress can help, like I said, it is about innovation, so we need to make sure that bipartisan support for robust biomedical research continues. But we also need to do the work through the rest of HHS and DOD and VA on reaching people with prevention. We need to prioritize prevention. We know that that's how we save money in the long run, is preventing disease in the first place. And so I think if we could come together around a really preventative mindset and do the work we need to do, that would be a huge benefit.
That's a good note to end on. Thank you, Danielle, for joining us. Please thank her for joining us. I'll hand it back to Sarah.
Appreciate it.
Hey, great job. Thanks so much.
Thank you, Dr. Carnival. Following on our previous discussion, even with the tremendous progress that we've made, cancer continues to be the second leading cause of death in the United States. According to the American Cancer Society, there will be over 1.9 million new cancer diagnoses this year and over 600,000 deaths. In addition, cancer care costs the U.S. $208 billion each year, and many patients are not able to access the benefits of the cancer innovation, particularly those from historically underserved communities. Our expert panelists are here to address the issues and more. Please welcome Dr. Clifford Hudis, the Chief Executive Officer of American Society for Clinical Oncology. Dr. Karen Knudsen is the CEO of the American Cancer Society for the American Cancer Society Cancer Action Network. I hope I got that correct. And Dr. Stephen Ubel is the President and CEO of Pharma.
Yeah, that's right.
An association representing America's leading biopharmaceutical research companies. Welcome, everyone.
Yeah, thanks for joining us. Great panel here. Let me start with, go down the line, start with you, Cliff. Kind of the one takeaway you want the audience to take away from this conversation. Usually we get to that point, but what do you want to emphasize? Because when I tell our reporters, that's got to be the top of the story. That's got to be the lead. What's your lead?
In a run-on sentence?
Yes.
We have made astonishing progress over the last decades against cancer, but not everybody has benefited evenly or equally. And we need to strive to accelerate the progress and spread that wealth.
Okay, that's great.
Yep, breakthroughs since 1991, which was the high watermark for cancer mortality rate in the country. Overall cancer mortality has been reduced by 33% through investment in cancer research. But we need to push forward to ensure that there's access to these breakthroughs, which will require policy and also addressing direct patient support across the U.S.
Steve?
The risk of going last. I agree with everything that's been said. I think we're in cancer moving from what used to be referred to as science fiction to science and action. So CAR T has been mentioned, taking cells out of the human body, reintroducing them on sort of smart bomb missions to kill cancer cells and spare healthy tissues. It's not just early diagnosis and new treatments, but also prevention. Dr. Carnival mentioned this. I think vaccines are underappreciated. You think about, girls who've been vaccinated for HPV have a 90% less chance of developing HPV, and I think there's some really exciting advances on the horizon in the vaccine space. So, yeah, super exciting time. We have to ensure we have equitable access, and the policy environment is concerning, and I know we'll touch on that.
And let's jump right in with that one. I remember many years ago being with a lot of health stakeholders, including you, Steve, and the effort had started to pass the Cures Act. And as you remember, it was bipartisan, but I got to the end of the year and it was touch and go. And that legislation, now law, has been received well. The Inflation Reduction Act was not bipartisan. And I want to get kind of your take on kind of those two bills, but in particular, why you have a problem with the IRA.
Yeah, I think that, first of all, I mean, let's start with, one of the few good elements of the IRA is there's an out-of-pocket cap of $2,000 for seniors. That's going to be a really impactful policy. Another policy we supported is allowing seniors to be able to spread their costs across the calendar year. So you don't have sticker shock early in the year where you have to meet your deductible. So that means that no senior is going to pay more than $167 a month for their medicine. That's a really important reform. Unfortunately, the price setting provisions of the IRA are really already throwing sand in the gears of the progress that we just talked about a moment ago. And I'll try to explain what I think is the most acute problem we refer to as the pill penalty. There's two types of medicines, small molecules, which are pills, and biologic medicines. The IRA sets forth 2 time frames before the government will set the price of the drug. 9 years for small molecules, 13 years for biologics. So what's the problem? First of all, small molecules have some special attributes. When you're talking about cancer, there are certain proteins that you can only go after with a small molecule. If you think about mental health, small molecules are the only medicines that can penetrate the blood-brain barrier. We're talking about equity. It's a lot easier to access a pill than it is to go get an infusion or go to the doctor, go to the hospital. So the pill penalty, what we refer to, though, is that 9-year time period. So the FDA requires you to test your drug in the sickest patient population first. And then only over time, as you gain experience with the medicine, physicians may use it in concert with other therapies or in other adjacent disease areas. You might get positive signals that actually, let's say a breast cancer medicine is working well in colorectal cancer or other types of cancer. The problem is 60% of the time, those positive signals occur in year 7 or later. And those trials, if you decide to pursue a trial for FDA approval, can take several years. So if the government's going to set the price of the drug after 9 years, but you're not going to commence a study until year 7, you have 2 years to recoup your investment, we're already seeing a flight of those research projects being canceled within our R&D pipeline. So this is a really acute problem that's going to really impact the fabric of incremental innovation and getting additional indications in other disease areas. Many cancer medicines have 10, 15 indications that are grown over time that are really going to be jeopardized by the IRA.
Karen, the Cancer Cures Act was a big initiative, as I mentioned, from both parties, but it was a big deal for then Vice President Biden. As president, how is Biden doing in the fight against cancer?
Yeah, well, we're very enthusiastic about some of the progress that has been made since the moonshot has been reignited. Just a few examples come to mind. In addition to the investment in cancer science and in cancer research, it's the case that policy changes that affect millions have been pushed by this administration. So up until January of this year, if you tested positive at home for colorectal cancer risk with something like stool-based testing, FIT testing, then now you face a penalty at the level of the next most important step, your colonoscopy. It was no longer completely covered because now it was no longer screening, it was diagnostic. So these are the kinds of policies that actually truly presented barriers to care. People were screening positive at home and then not going to their follow-on colonoscopy. So, an incredible advance that was pushed by the Biden administration was to ensure that this follow-on colonoscopy was now completely covered. And they proposed this to CMS. This happened as of January of this year. As you sit here, that became reality, and that can affect millions. One of the ones that we're very excited about that will come into effect in January of this year is a realization of something we've been really advocating for based on evidence for years, and that's patient navigation. So oncology patients who are navigated understand their care. They're much more likely to complete their care as planned. They overall have a better outcome because of those two attributes. But it's also the case that the health system wins. Those patients, we heard about value-based care in one of the previous panels. those patients largely do not end up in the emergency department and have an overall lower cost of care. From the American Cancer Society perspective, this is what we call all boats rise. So educating elected officials, working with the Biden administration and with other organizations, we were able to successfully advocate for this. And as of January 2024, lay patient navigators will become a reimbursable component of cancer care. And if we look at the evidence and try to identify what is a singular action that could be taken in order to enhance equity in cancer care outcomes, it's patient navigation. So we're very thankful to all the partners who helped us get that done, but especially so to the Biden administration. So I think these are two great examples about using the White House as a way to get access, to get enhanced access to breakthroughs to patients.
Cliff, you've said that simply ensuring patient access to state-of-the-art care would improve outcomes by 20%. That's a lot. Can you explain that?
Yeah, so as we know, there are a wide range of experiences for patients diagnosed with cancer, and Karen just highlighted just one of the examples. In those states that have expanded Medicaid, we've had a real-life example, demonstration of what happens. Disparities in terms of time to diagnosis of cancer and time from diagnosis to the treatment of cancer have been narrowed and eliminated, and classical race-based differentials have been eliminated in those states as well, colon cancer being a concrete example and others. So there's a broad set of data that consistently points to about a 20% lack of high-quality outcomes in people who are disadvantaged in accessing the healthcare system. That's where that estimate comes from. If we address that lack of access, we could close that. And I want to emphasize something about this because this is low-hanging and, forgive me, cheap fruit. We can develop all the exciting new treatments that we want, and we can make bold advances in treating a variety of diseases, but we could almost overnight make the single largest population-based advance in cancer care outcomes if we eliminated these gaps.
You mentioned cheap, and Steve, I want to go to you because obviously when moving legislation or talking about healthcare, cost always comes up. But as Sarah was mentioning the stats, it's stunning how much cancer really, it just causes so much pain, and it also is expensive. But then you have lawmakers, some, who say, well, we can't spend that because we don't have the money. So can you talk about prevention and how that factors into policy making and convincing the people who are making the decision, no, this is actually cost effective, but you got to invest?
Yeah, I mean, I think that first on the equity front, I do think it's multifactorial, but it'll get to your question. One of the biggest impediments is out-of-pocket costs for medicine. And research suggests that Black patients abandon their medicine after medicine costs $125 or more. And to me, that points to the need to really make sure that we're looking at the system as a whole to address inefficiencies that cause patients to pay more for their drugs than they should. We've long talked about inefficiencies, whether it's health plans and PBMs or whether it's hospitals in the context of the 340B program. Drug manufacturers are now capturing about 50 cents of the dollar of the list price of a drug. That means the rest of it is being absorbed by other actors in the system. And we know that this arbitrage is really swelling in the system. So whether it's plans and PBMs that are capturing these enormous discounts and not passing them on to patients, or the 340B program where they're getting massive discounts on drugs, 50, 60%. Hospitals turn around and mark up the cost of the drug by 500%, but no requirement to actually pass that on to patients in the form of lower drug costs. So we've been leading this advocacy around making sure that we're making efficient choices to ensure that patients are paying less at the pharmacy counter for their medicine.
Karen, what do you hear from consumers / patients / caregivers that maybe you don't think politicians hear enough?
Yeah, well, let's talk about cost of drugs. So what we know, because we're our key stakeholders, our patients and caregivers across the country, is that 42% of individuals in this country diagnosed with cancer deplete their life savings. That's unacceptable. We also know that financial toxicity is a real toxicity. That is correct. So all the data tell us that this, like any other adverse event of going into a particular cancer therapy, is a reality that's associated with poor outcome. So these are things that have to be addressed. But it's not cost alone. Something that, as we go around the country and support patients in 5,000 communities, that we consistently find that people don't understand enough about, it's what we call the basic blocking and tackling of cancer care. So when I was a healthcare executive leading oncology for an 18-hospital system, 16% of our patients could not complete their care as planned because they didn't have a ride. Things like transportation, lodging, are key determinants of whether or not someone is actually able to complete care as planned. So ensuring that those basic elements of access to cancer care, understanding that cancer patients are frequent flyers, 5 weeks in the chemotherapy unit, 5 weeks at radiation oncology, it's just not tenable unless someone lives near a center for advanced care for them to get access to participation in a clinical trial or to make a life-saving decision about the kind of care that they will receive. Unfortunately, these social determinants of health, which include transportation and lodging, are key factors that, just like understanding the biology of disease, need to be addressed.
Same question to you. Cliff, what do you think?
Well, this is actually a pet peeve of mine, and it picks up on what Steve highlighted and what Karen talked about. So I want to just paint a scenario to you for a moment.
Okay.
Novel therapies come through the academic and development pipeline. They're evaluated by our membership. Guidelines are written. Quality standards are established. Metrics are generated. Reports are generated. From all of that, FDA approval is garnered. Payers agree that there is a pathway on which that treatment falls, and they agree that that's the optimal treatment for a patient. A doctor prescribes the therapy. They go through a rigorous, onerous, burdensome, and time-consuming pre-authorization process. So the payer has now agreed that the patient is being treated the way everybody says they should be. They go to the pharmacy to get their pill prescription like Steve described.
Right.
And what's the last thing that happens? They're asked for a copay. Why? Everybody's already agreed that they should get the therapy.
Right.
We've added a barrier to compliance, and there is high-quality evidence that is consistent in this way. The more the out-of-pocket expense, the lower the compliance. It is that simple. So tell me the rationale in our system for putting all this investment in to make sure that everybody's doing the right thing and having the final step be an overt impediment to compliance which has zero other benefit or function. The most extreme example is from about now 15 years ago when imatinib came out, an oral therapy that revolutionized chronic leukemia. And so revolutionary that I had friends whose spouse diagnosed with CML was dismissed by them as, oh, it's just CML. You have to appreciate as a medical oncologist when I trained, there was no just CML. That was a difficult treatment pathway ahead. So with imatinib, oral pill taken with an out-of-pocket expense, there were academic papers that showed that compliance fell with each $5 increment in the out-of-pocket expense. And from my point of view, we should be paying people to take the drug because it reduces the total cost of care, delays the use of much more expensive therapies, keeps them in the workforce, paying their insurance premiums, contributing to their employer-sponsored healthcare plan. So I'm sorry to go off on this, but this is an example of the most basic, fundamental non-alignment of resources. And I have to say, there is no particular defense for this. It just is.
And I don't want to interrupt, but one of the symptoms of financial toxicity is reducing drug intake.
Right.
So the way that people handle that is actually by having pills and then trying to meter it out, thinking that half is better than none, which may or may not be true, but is often associated with a reduced opportunity at a positive outcome. So Dr. Hudis is spot on.
I just think we should charge everybody $10 or more for their insurance and not have out-of-pocket expense.
Mm-hmm. This is actually very unique to medicine.
Yeah.
If you or I go to the hospital or the doctor, we're paying the negotiated rate between the insurer and those entities. It's only with regard to drugs that you're showing up at the pharmacy or the hospital or doctor. You're paying oftentimes the full list price of the drug, even though there are all these other efficiencies in the system, whether they're rebates and discounts or discounts in the context of the 340B program. So we have to rationalize the intermediaries in the system so that we can lower costs for patients.
Yeah, and I'm sorry, but I just have to simplify that. We've all agreed what the best treatment is. We've all agreed that this is compliant. We've all agreed it should be paid for. But the last thing we do is make you pay a little more.
Mm-hmm. Steve, your company's association clients of pharma are at the forefront of innovation. What are you excited about? Because innovation doesn't really attract a lot of headlines, but then we start to see, I mean, really no one was talking about AI 4 or 5 years ago, and now it's going to revolutionize basically every industry, including journalism. What are you excited about in the next 5, 10 years?
Yeah, I mean, it really is the tale of two cities. It's never been more exciting on the science side for our industry, and it's never been a more toxic political environment. I'll touch on both. I mean, you think about what's happening every day. There's a headline, we have curative therapies on the horizon for wretched diseases that not only impact patients from a human suffering perspective, but have enormous downstream healthcare costs and societal costs. Diseases like sickle cell disease, hemophilia. These are patients that are visiting the emergency room frequently and just enormous suffering that are going to have curative cell and gene therapies. We've talked about some of the advances in cancer. But on the flip side of that, I mean, just today, the administration is announcing this new framework for march-in rights that's going to allow the government to potentially seize your intellectual property or set the price of your drug if you collaborate with government. Which, the U.S. ecosystem innovation, the reason it leads the world in the development of new treatments and cures is that our companies can collaborate with government, can collaborate with academic research centers. Everyone shares in the fruits of those discoveries if they occur and become commercialized, all for the benefit of patients. It is the envy of the world. I was in Tokyo 2 weeks ago. Mm-hmm. All the Japanese leaders, including the Prime Minister, are enamored with Cambridge, Massachusetts. They want to recreate one of the high-performing clusters in the United States. How do they do that? They're looking at the Bayh-Dole Act. What's our administration doing? They're going to undo the Bayh-Dole Act, which enabled this collaboration to occur. If the price of collaborating with the government is that your patents are going to be seized or the price of the drugs is going to be set, there's going to be a lot less collaboration. That's going to jeopardize our health security, cede our leadership, and it's really going to cost patients future treatments and cures.
Karen, we're going to go back to access issues and gaps and cancer screenings. And you tell us a little about the Color Health initiative.
Yeah, Color Health is something, it's a unique partnership that we lifted up just a few months ago between the American Cancer Society and Color Health. Now, Color is largely a genetic testing organization that assesses, essentially democratizes someone's ability to understand their own cancer risk. Developing a tailored, bespoke screening plan for any individual is about more than just their age. It's about their age, their family history, their genetic history, and their exposures. So the Color Health ACS partnership is meant to get rid of the friction points that reduce individuals from going into cancer screening. We know that screening and early detection has to be part of ending cancer as we know it for everyone. So what we're doing is working with this program with mid and large size employers to bring on this partnership at the level of their HR benefits so that people have an opportunity to understand how and work with us with our guidelines and Color's genetic testing to develop the right screening program for them and then navigate them. So within your existing already paid for health plan, your colonoscopy is covered. Let us help you get the appointment to that person. It meets all of our goals toward getting more individuals into prevention and early detection.
Mm-hmm. Cliff, just want to talk about the disparity between healthcare across the country. Do you think that how much of a problem is access to care and quality care in rural areas of America?
It's a huge issue, and it's getting wider. As we make these advances against cancer, we see falling mortality rates. They are not falling as steeply or as quickly in rural areas, which suffer both the burden of, in many cases, lower socioeconomic status and the added geographic burden in terms of access to care. The remedies, I think, are on the horizon there. Obviously, the broadened access to care through the telehealth liberalization that came out of COVID has been very helpful. Reducing the administrative overhead related both to care and clinical trials has enabled patients in those areas to participate in cutting-edge treatment and research more easily. We have a project at ASCO in Montana that uses a hub-and-spoke model with a center of excellence in a larger city, and then nurse practitioners, physician assistants, and internists and others in a rural site hundreds of miles away, guided by the center to deliver prescribed care and monitor the patients. And we think that's going to be a scalable way to begin to address this challenge. By the way, I think it also will probably work internationally to deal with disparities as well. So it's universal.
Let me go a quick lightning round as we finish up. Steve, we'll start with you. Just something positive, and with mixed in, are these goals from the Biden administration, Congress, on cancer achievable?
I think they are achievable. You know, there's a lot of tailwinds behind us on the science side, but I worry that we're sort of sabotaging the rocket that's trying to achieve the effort. So I think we need to nurture the ecosystem that has produced a lot of the innovation that's occurring and not throw sand in the gears.
Karen?
Yeah, I would say exactly that. Let's keep up the momentum, and let's also leverage some of the big wins we've had in actually having a cancer vaccine that has now given us the first, as of this year, real-world evidence that we can end cervical cancer as we know it and other HPV-associated vaccines. We've just got to take action as a country and get people vaccinated, and to build on the opportunities that we learned about with COVID and mRNA vaccine technology and leveraging that toward new cancer interventions.
Cliff, last word.
Sure. So I think that the 30 or 40 years now of progress is not going to be slowed. I think the scientific advances are remarkable. And I think I'm optimistic because despite all of the political infighting, we've actually reached a point where the highest proportion of Americans ever are insured and have access to care. And I think we have to figure out a way, an affordable way to continue those trends. Every study we do that looks at addressing these disparities and closing these gaps shows deliverable improvements in health.
So there's a lot of hope out there.
Absolutely.
Well, please thank our expert panel for joining us this morning. I hand it back to Sarah. Hey, Cliff, great job.
Thank you again to our panelists. And now, a word from our sponsor, AstraZeneca. Please welcome back to the stage Joe Ruffalo, General Manager of The Hill, joined this time by David Fredrickson, Executive Vice President of Oncology Business Unit with AstraZeneca. Welcome. Thank you.
Thank you.
Hello, David. Thank you so much for being here today.
Absolute pleasure.
Why don't we start just telling us a little bit about your role and the role that AstraZeneca is playing in the oncology space and some of the things that you're excited about.
Yeah, well, super. I think maybe if I just start first with my role, the role that I have is that I, alongside with my colleague who's the head of research and development, we make the decision on the medicines and the clinical trials that we want to be advancing forward. But I think secondly, and this is really kind of what my whole day-to-day is about and what I think we heard a lot about in the last session, is it's not just about how do we get to great clinical trial results, but ensure the delivery of those medicines across the globe. And so that is a core part of the work that I do, which is focusing in on what are the gaps in care. We heard Dr. Carnival talk very exquisitely about the need to start thinking about screening, diagnosis, how that then moves into access to medicines, innovative medicines, and on through survivorship. We heard Dr. Knudsen talk about the same from the context of a great and I think very important example in colorectal cancer. So my role is really to try to understand how do we close these gaps in care that are essential to achieving the best possible outcomes. In terms of what I'm excited about, I actually think that we are at a place where it is no longer science fiction to think about what eliminating cancer as a cause of death could look like. I think that cancer is a disease that comes in multiple forms. We oftentimes simplify it so that it's approachable, I think, for kind of the lay audience, but I do think in many of its forms, the progress that we are making on science and technology and data is creating a real optimism that there is an opportunity to be able to deliver these cures. And I think that AstraZeneca is at the forefront of leading a lot of that work and a lot of that effort.
It's great. It's an exciting time. In the wake of the Inflation Reduction Act, there's been a lot of discussion about the impact it could have on the innovation pipeline. What are you seeing?
Well, I think it was really quite nicely put by Steve Ubel in terms of, and in fact, Dr. Huddis's example was very poignant of how copay has a direct impact on adherence to and fulfillment of the utilization of medicines. I think it's important to note, and the reason why I think that within IRA, one of the important parts is copay capping, and this copay smoothing is so important, is that actually for many private or so-called commercially insured patients, industry is able to work to actually reduce the copay down to zero. But anti-kickback statutes make that not possible for Medicare patients. So actually, within this context, it's really important that IRA is having the government take a role in making sure that the statute allows for copay affordability support in the way that it does. Unfortunately, the IRA does have some areas of unintended consequences, and I think one of the most notable of these is with price setting. And I guess I'd like to bring that example, Joe, to life for a second. So AstraZeneca's launched 7 new oncology medicines since 2014. Of those new oncology medicines, all of them have multiple indications or multiple types of cancers that they've now been approved for use in the United States. And for about half of those, the first indication that we launch into has been in a very small orphan indication. So one example is a medicine of ours called Lynparza. Lynparza launched in 2014 into BRCA-mutated second, third-line ovarian cancer. We went into that space in large part because there's huge incentives to move science quickly through things like the Orphan Drug Act. And the Orphan Drug Act has created a space for 600 medicines and over 1,000 indications in rarer cancers to become available to American patients. And the BRCA ovarian cancer approval is a very example of that type of situation. Unfortunately, with the IRA, with the price setting mechanism that comes in place, it creates a huge disincentive to launch into these smaller, very rare cancers. And the reason is it starts this negotiation clock of 9 and 13 years that Steve talked about. And so the implication will be that we'll still do the investments into rarer cancers. It's just we will launch them into other parts of the globe, and we would wait to launch them into the United States until we've actually got a rational reason to start this negotiation clock. And that's a decision that nobody in industry wants to take. And for that reason, we are really focused in on how can we make technical fixes today to the implementation and the rules for the Inflation Reduction Act to preserve this incentive for innovation into these rare cancers and rare diseases. And we need to have those incentives into rare diseases because there's nothing more inherently inequitable than a genetic reason that you have a rare cancer. And it's small, and these are small costs to the entire population and society, and they need incentives for people to be able to want to invest in them.
So what are some of the changes you really want to see in the IRA?
Well, I think that the here and now opportunity is that there is a bipartisan introduced bill called the Orphan Cures Act, and I'm just going to read because otherwise I'll get it a little bit wrong, but it's Optimizing Research Progress, Hope, and New Cures. It's Orphan Cures. It's bipartisan. It's been put forth within the House from Congressman Nigel as well as with Congressman Joyce. Within the Senate, it has bipartisan support from Senator Carper and also from Senator Barrasso. And really what it does is it looks at preserving the incentives from the Orphan Drug Act, and there's mechanisms in IRA to allow for an orphan drug exclusion to price setting, and it puts technical fixes around when the clock starts and when it ends that protect orphan indications and protects the incentive to exist there. And that's been moving forward, and it's at a place where it's in committee, and I think there's opportunity to see that there are both sides of the aisle that are interested in making sure that these incentives are preserved, because I think that they're really unintended consequences of a piece of legislation that's trying to get at some other dimensions and weren't intending to try to create disincentives in these spaces.
That's great. Well, David, thank you so much for your time today and your insights and all the work you're doing.
Yeah, thank you very much. My pleasure.
Thank you.
Thanks.
Thank you again to our sponsor, AstraZeneca. The Hill's Cheyenne Daniels will interview our next guest. Dr. Julie Lewis-Gerberding, who ran the Centers for Disease Control and then pivoted over to private sector to work at Merck, is now the CEO of the Foundation for the National Institutes of Health. Welcome, Dr. Gerberding.
Thank you. Good to be here.
Dr. Yes, thank you so much for joining us today. We are going to talk a little bit about the importance of partnerships and trust today. So I want to start off, in your work at FNIH, there's a major focus on public-private partnerships, and you've called the successful partnership team science in its highest form. Why is that important, but especially for our patients?
Well, thank you, and thank you for having me here today. You know, when you step back, despite all the incredible advances in science, we still have some really tough challenges to solve in healthcare. And these challenges, like mental health or metabolic disease, et cetera, really not going to be solved by a single life science company or a single NIH institute or a single investigator. It's going to take a partnership, wise crowd. It's actually tough for the government to work directly with the private sector, so organizations like FNIH really provide the middleware to bring these partners together, to raise the money to really accelerate their progress, and to kind of herd the lions so that you move the needle down the field, the needle on the dial in a way that really advances the decision process and gets the job done. So you don't swarm the problem, you have an organized project managed approach.
We know that there's oftentimes this perceived sort of like competition, I guess, between public and private, and how do we handle it? How do we sort of dispel that notion if we're looking for that team science element?
You know, the most important thing in aligning the partners is the shared agenda. What is the overarching thing we're trying to get done? For example, partnerships like the Accelerating Medicines Partnership are a pre-competitive set, mostly of life sciences companies and NIH institutes, who fund investigators to try and identify new targets and new pathways in the more discovery phase of science development. And when you agree that that's the agenda, you can get people to really focus on, wait a second, what is it that we're trying to accomplish here? And I think one of the helpful secrets to that is to involve the patients and their communities in that effort from the very beginning. So at FNIH, for example, we have patients who are not just there as a N of one, but who really participate in the end-to-end development of the science. In fact, in our AMP for schizophrenia, the co-chair of the steering committee is a person with lived experience in schizophrenia. So that really also motivates people to always remember, oh, why are we here? Oh yes, we're trying to find better therapies for schizophrenia. And some of the other issues that can complicate the interpersonal relationships fall to the side.
Yeah, and I love that you brought up about lived experiences and having that connection with individuals who have a lived experience. In particular, really when we think about mental health, there is more and more attention being paid to mental health and mental illness over the last few years. How do we continue to improve, not just removing the stigma, but making sure that those with that lived experience are involved in partnerships like this?
Well, it is tough because reaching out into the mental health community and finding those people who A, have the time and the capability, but B, can get past the stigma and the challenge just inherent in carrying that diagnosis. Not everyone is willing to be forthright in a more public way. But I think the broader issue isn't the participation of the patients, it's the lack of progress in the science. And we really need to accelerate the science of mental health disorders in the same way we've been able to accelerate the science for cancer, for example. But we are not finding a lot of new targets, and we're certainly not seeing a lot of life science companies really prioritize investment in mental health. So we do need to try to revitalize and energize. The National Institute of Mental Health has a very fine agenda to try to accelerate these efforts, but we need partners. And this is actually, for me personally and for FNIH, a really high priority for us.
I know another high priority or focus has been maternal, child, and newborn health. And we discussed this a little bit earlier with Congresswoman Kelly, but why is this such an important focus at this time?
Well, on a global basis, but even just focusing on the United States, our maternal health data are embarrassing at best, and in my opinion, tragic. To have a country with so much capability really have one of the worst maternal mortality rates of any developed nation, and worse than many undeveloped nations, is a tragedy, and it really speaks to the failures of our health system and the profound inequities that underpin it. So I think first and foremost, the problem is a glaring performance indicator of what's wrong with our system. But we also know how to fix it, and I think systematically tackling the three biggest contributors to maternal mortality: number one, infection, eclampsia, and the complications of birth in that sense, and then bleeding. We have medicines that can easily address these things, but we don't have our systems of care that assure that women are treated respectfully and have access to the early recognition of their risk and the appropriate interventions in the obstetrical setting. We can fix this, and in places that have really made that commitment and kind of implemented the airplane pilot approach of the check sheets, et cetera, we really can see improvements in maternal mortality, but we got to get serious about this.
One of the things that you mentioned there was about, and I might not be using the exact same word, but that element sort of like the respect to the patient. And I know particularly in communities of color, and I think many of us know particularly in Black communities, there is an element of distrust, in part from many experiments and previous history that could be pointed to, but also and something the Congresswoman spoke to is systemic racism. How do we begin to address the distrust that some of our communities have for our science and medical communities?
That's a hard question to answer shortly, but I think the first principle is basically trust is earned. And we have a history that has certainly caused a very rational decline in trust in some communities and in some patient populations. So we have to accept that. But you don't really combat trust with facts and information, however credible they might be or evidence-based they might be. You earn trust by really recognizing that people make decisions and judgments based on their values and their beliefs. And in order to really influence how those decisions are adjudicated, we have to, first of all, bring people to that conversation who have intrinsic trust. That's not always the government official. Often it is your personal doctor or someone in your community that you see as like you or who understands your circumstances and your value system. So to really engage at the community level in helping people process information and hear information translated by people that they really already trust. It's a long process, and it's not going to be easy to restore the trust that's been lost, particularly in recent years, but it can be done, and it's going to take all of us. I think part of the problem is that the people who are credible and have something to contribute often don't participate in the conversation. So we all have a little responsibility to influence the people in our world who share our values and beliefs in ways that help them be part of the force of making good health decisions, but also restoring that trust.
Yeah, and I like that you mentioned that it is something that has to be involved with everyone. But I have to ask, because we are in DC, is there anything that our political leaders could be doing to help, whether that's with the partnerships or the community-based level of rebuilding that trust?
Well, that's another very hard question. I'm glad that there are members of our government, our White House certainly, and some of our members of Congress who see this as a critical priority. But I also see plenty of people who are either intentionally or inadvertently detracting from that trust. And I think that's something that as Americans we all have to take ownership of, because we elected these people, and we need to make sure that we're looking for people who understand the process of science and respect it and are willing to participate in healthy controversy and debate, but not in polemics that distort or really use distortions of science for political ambition and aims.
Absolutely. Dr. Gerberding, thank you so much for such an important conversation. Really appreciate your time today.
Thank you for participating.
Thank you, Dr. Gerberding. Next, we have our third and final panel of the program, Obesity Treatment, Access, and Equity. Please welcome back Bob Cusack, along with Nancy Glick, Director of Food and Nutrition Policy at the National Consumer League, Dr. Jesse Ernfeld, President of the American Medical Association, and Dr. Bill Dietz, Director of the Redstone Global Center for Prevention and Wellness at the G.W. Milken Institute for Public Health. Welcome.
Thanks, Sarah. Nancy, let's start with you. Your group is putting together an obesity patient bill of rights. Tell us about that and how people with obesity really don't get the respect and attention they deserve.
Okay, do you all have like hours? Okay, so I am so grateful to be here. And of course, you heard Ramsey talk a little bit about this, our partner. So we basically came to this decision that America needs an obesity bill of rights because we asked a question, which is how come? How come obesity just keeps getting worse? And if you look back 20 years, a lot of the things that we're talking about today were known then, but Americans, I did the numbers, and if you count the number of people who have overweight and obesity, it's 73% of the adult population, which means that people like me are a minority in this country. And that's pretty depressing. So we started in 2021. We're part of a group called OCAN, the Obesity Care Advocacy Network. And a lot of people in this room are part of this because obesity is directly impacts cancer, heart disease, the whole group. So a lot of us are aligned and trying to solve this. And we partnered bringing together an expert panel. And we said, okay, so what's the state of obesity and why is it only getting worse? And what we learned is it's not because there isn't good science, there's amazing science. Things have changed. We now understand that this actually has something to do with brain signaling. So, and it's definitely not, let me put in capital letters, a problem of moral failure on the part of people who eat too much and just don't have discipline. Let us just decide today that we stop thinking that way. And that is a big challenge. So what we learned is not the science. And for years and years, there have been obesity treatment guidances. Bill, when he was in the government, was working on this. So there is a long history. Okay, so that's the good news. Okay, so why are people not getting care? Well, it turns out we call it the human obstacles. The first is this terrible outdated thinking, and some people today even were sort of discussing, let's just walk more. Let's buy a book and read about, calories. That's fine. And, I don't disagree with that. But at a certain point in time, people are beyond that. If you have significant amount of weight that walking is great, but, I'm sorry, if you have 100 pounds, I think we need to do more than that. So there's that outdated thinking. Then there's this pervasive stigma. I mean, it is oppressive. And it is the health community, it's employers, it's insurers, and I would submit it's policymakers. So we have a lot of people who sort of consider people with obesity as less than. They did it to themselves. Why should we, worrying so much about this? Well, because we're all paying for it. And the next is that we don't have a healthcare workforce that's prepared at this point to treat most of the people with obesity, because there's not training in medical schools. A lot of people, just basically don't know where to get the information. So we're sort of in a sort of a continuous loop here. And then there's the famous access issue, which is just astonishing. So, you heard Ramsey talk about the fact that Medicare does not cover these new obesity drugs, because when Part D came into effect 20 years ago, there was a whole different situation regarding weight loss drugs. And so they were excluded as cosmetic. Well, times have changed. So we look at the healthcare system and we go, wow. From beginning to end, we have an issue. And I just want to just pop off a few numbers to tell you why I'm so hot about this kind of thing. And so I'll just start with 1.72 trillion. That's 12 zeros. That's how much this country spends a year, and it's the economy writ large. So it's direct healthcare costs, indirect healthcare costs. It's lost productivity. It's disability. I mean, we were talking about, the massive cost for all healthcare. Well, consider 1.72 trillion of that is obesity. So next is 110 million people. Pretty big, huh? 42% of the adult population that has obesity. And again, that is like a record number. The next is 400,000. That's the number of people who die now prematurely from obesity every year. The same as cigarettes. Okay, so, we're losing people prematurely to a disease called obesity that most people don't understand is a disease. 230, the number of chronic diseases directly related to obesity: cancer, heart disease, hypertension, osteoarthritis. And then we get 10. I'm just going in reverse order. The percentage of Americans today actually have received medical care for obesity. Terrible. And then 2. That's the percentage of people who have been able to get access to these new anti-obesity drugs. The numbers, I don't have a lot of hair, but if I did, it'd be on fire. So we basically decided, as we're advocates, we're consumers. So we looked at this very differently. We went, well, wait a minute. If everybody else is sort of in this continuous loop, and we're having lots of meetings, we're having lots of discussions, and we can't break this system we're in, then maybe we have to break glass. Mm-hmm. And so we decided with the National Council on Aging that we were going to go directly to the public, and we're going to say to them, if you have diabetes, You go to a doctor, you get diagnosed, you get prescriptions, you get seen. Well, suppose you have the disease of obesity. Why can't that happen for you? And so we want to empower people to ask questions, to demand to be treated, and we want to sort of change the dynamics so that basically, as somebody said, we become the people in charge.
Right, right.
And my fiance, wonderful man, is a ordained Presbyterian minister, so I've started to think biblically now. And I decided, I just had this brainstorm, I don't know, I didn't have enough breakfast, about Martin Luther putting, 500, points on a church wall and starting the Protestant Reformation. So I want our Obesity Bill of Rights to do that.
Okay. Jesse, let me bring you in here. Tell us about the physician perspective on treating obesity and how doctors are pushing for insurers to cover obesity treatments.
Sure. So thanks for having me. This is an important discussion. And the AMA recognizes obesity as a disease state. And that's a really important starting point when we think about treatment, access, and frankly, the stigma that is preventing people from getting the care that they need, that Nancy has described. 1 in 5 kids struggle with obesity. 1 in 3 adults struggle with obesity. We can only start to reverse this tide if we treat obesity as a disease and we make sure that people have access to all of the therapies, treatments, interventions, and strategies that take a whole variety of approaches, including obviously the new medications that are coming online. So we worry about carve-outs for particular treatments that we know have evidence behind them. We worry about access to treatment for obesity writ large. And as we think about making sure that we can elevate the health of the nation, those are obviously priorities for the AMA.
Bill, just regarding new drugs and treatments on obesity, and there's been a lot of headlines on that, and that's great. But how do we tackle obesity in a comprehensive, long-term fashion?
Well, the first thing to say is that we're not going to be able to treat our way out of this disease.
A lot of people think that now.
Right, that's right. And these medications are enormously promising.
Right.
That we now have medications that have that reduce obesity by 5% of body weight in 85 to 95% of the population. And the most recent drug, tirzepatide, accounts for 20% weight loss in over 50% of the people who consume that medication. Yeah. So that's great. But I worry about
it's not 100%.
No,
right?
It's not 100%. Well, but it's getting closer to surgery. And that's the important point to make. There are limitations to these drugs. That expense is a major one. That the semaglutide, Ozempic, costs $1,300 a month. The tirzepatide is about $1,000 per month. Ozempic is about $800 per month. So these are extraordinarily expensive medications, particularly since long-term adherence to these medications is going to be required.
Do you think that will go down a lot over time or no?
I think that that Lilly's tirzepatide is already competing with semaglutide, which is the Novo product. But that said, there are lots of barriers around care. Jesse mentioned one of them, and that is physician training. And my biggest worry is that the kind of counseling which Nancy described, which dismisses obesity as a personal failing, in which providers say you just need to move more and eat better, that's now going to be replaced by take this medication and everything will be hunky-dory. And that ignores the fact that primary care don't know how to treat obesity, and that the medication alone is not going to be sufficient, that it has to be surrounded by other behavioral reinforcements, so that we know that when the medication, when this plateau in weight loss occurs in response to the medication, that we need to sustain that with strategies other than continuing the medication. because that's going to be enormously expensive. It's a lifelong kind of problem. And I think in that context, the focus on behavioral change, intensive behavioral therapy, has been lost. And we know that that's a very effective kind of strategy. And the best illustration of that is that the most recent trial of tirzepatide, SURMOUNT-3, selected patients for that drug based on 12 weeks of behavioral change. And those individuals who enrolled in the trial had to lose 5% of their body weight. If you look at the curves of their weight loss, the slope is indistinguishable from that of tirzepatide, emphasizing the importance of this kind of intervention. Now, all that is said around treatment, but as I said at the outset, we're not going to be able to treat our way out of this. And my hope is that that recognition and the expense and the kind of prevalence of treatment is that we're going to lose our focus and the need to focus on environmental strategies. So one way of thinking about this is that the medications have a internal effect, that they sensitize the individual to satiety, to a sense of fullness on the gut-brain axis. But we also need to think about the ambient environment, the external environment, because that's what's driving this pandemic. And I think we know some of those strategies for younger children, like WIC and like the universal school feeding. But we don't have in place the kinds of other strategies that are going to be necessary to transform the behavioral environment around nutrition and physical activity.
I couldn't agree more with that. We have to treat this as a public health problem, right? And there's so much attention on the new medications, and that's an important component, right? We need to make sure that we have access to therapy that has evidence behind it, but we also have to take a public health approach, right, to make sure that the SNAP program is configured in a way that we have access to foods that are healthy and nutritious. So we have education in schools so that kids in grade school learn how to make appropriate choices, so that we have places where people can actually go out for those walks and be safe and not be afraidful that they're going to be harmed when they're trying to get exercise. So those are all important sort of upstream drivers that we know can improve health, that are as important as the access to treatment when people have challenges with obesity.
And this is just a follow-up question on the challenges physicians face other than insurers. They face a lot of challenges. You have patients who see commercials and they ask their doctor about certain treatments. Yeah, how is that? I mean, we're going to see more of that, obviously.
We're already seeing some unscrupulous business practices, and I will tell you, it reminds me of about 10 years ago. I drive down I-65 in Nashville, where you still live, and I'd see the low T billboards.
Right.
Those have kind of gone away, but we're now seeing, online advertisements for compounding pharmacies that purportedly provide this medication. Well, this medication you can't get from a compounding pharmacy because the active ingredients are obviously proprietary, and there's a licensing agreement. So those things I think are going to harm patients, and we're very concerned about that. We want to make sure that that doesn't actually lead to challenges as this market is evolving.
So you're seeing a lot of people paying a lot of money for something that doesn't work.
That's a concern.
Yeah.
Well, there's this whole magic bullet aspect to obesity, which has been around for a very long time. Fen-phen, et cetera. And then there's this diet and grapefruit diet and all of that kind of stuff. And I agree with the gentleman here about this being a public health issue, but it is, we have to, I think, start by, again, empowering people to think about the whole concept of obesity differently. So the people who, a lot of them, these stars, et cetera, the Ozempic effect, et cetera, there's some very wealthy people who will always be able, because price isn't an issue, and they get a lot of attention for this. But the majority of the people today, are not thinking like that. And they're stuck in this feeling that, I'm a failure, I don't know what to do. They confront a situation where they have a hostile environment in terms of the fact that, physicians, nurses, et cetera, again, have this great bias. And so from our standpoint, I think it's a system-wide, which starts with prevention. Our Bill of Rights doesn't focus on that because we sort of deal with you at the point where, you are, quote, a patient.
Right.
And those issues are critical. It would be fantastic if we could do more there. But ultimately, I think we all need to work together to change the mindset of everyone about what we're talking about here. We're not talking about getting into a smaller, a dress size. And that still goes on.
Mm-hmm.
And we need, to have doctors who don't see this as I can make some extra bucks, but that this patient of mine has a disease and he or she probably has comorbidities as well.
Mm-hmm.
All these other things that you probably come into your physician with diabetes and you need to have help reducing your weight. So I think it's very important for us to sort of realize that this whole challenge of obesity, it is a hairy, big issue that, we have to confront, from education and, just working across the system to address it. And I would say, for example, employers who think that they're solving the problem by giving you a gym membership are not really helping you that much.
Right.
So we have to do a lot more than that.
Well, Bill, I want to pick up on that societal thing. And I've noticed over the last week in preparing for this event, you don't see many commercials on asparagus or on spinach. You see it on fast food.
Mm-hmm.
You see it on cheap food. Now, you can't legislate that necessarily, but that's a big impact, and obviously that's one of the reasons why obesity disproportionately affects minority populations.
Yeah. No, I'm glad you raised the minority populations because the disparities with respect to obesity are significant and socially determined. They're not genetic.
Right.
But we do see a higher prevalence in blacks and in Mexican Americans or Hispanics. And that does not have a genetic cause. That's a direct consequence, I think, of racism, of structural racism. And I think D.C. is a prime example of that, with only 3 grocery stores across the river.
Right.
And that means that these populations rely on corner stores for their food, many of them. And that food is ultra-processed food. This is one of the, I think, current foci of research. And increasingly, we recognize that ultra-processed foods, which contain very little real food, are an important driver of obesity and mortality. The reason for that is that they're high in fat, salt, and sugar. And they're delicious, and they're inexpensive, and they're widely available.
And they're addicting.
And they're addictive, and they have a long shelf life.
Yep.
So what's not to like about it? Well, this comes back to why isn't there better produce in those stores? Well, that's expensive. And the distribution network is limited. So I think that poses a real important challenge that we have to address if we're going to really resolve this problem.
Jesse, your thoughts on that?
Well, there are clearly policy options and opportunities to change the market, right? To make the nutritious things that can keep people healthy less expensive and more accessible, to eliminate those food deserts. There's a tremendous surge in interest in food as medicine programs, which can be highly effective. And in fact, in my day job in Wisconsin, I funded a bunch of those things because we've seen dramatic changes in terms of people's overall health, diabetes control, hypertension, challenges with high-risk pregnancy being tremendously impacted through the availability of appropriate nutritious food. So again, you have to take a public health approach. We have to make sure that the complexities around cost as a barrier, ethical questions about who gets access to what treatments and therapies don't overshadow some of the foundational work that we still need to do from a public health perspective to prevent obesity.
Let me just throw out body mass index. Is that a good thing or a bad thing?
Oh, it's a little controversial, and I'm sure Bill can talk about this as well. It's a screening tool.
Yes.
And, everybody who goes in for their physical gets on a scale.
Mm-hmm.
And not everybody has a conversation about it, but that information is available. And I think from our perspective, if discussed properly, it does allow for a conversation about whether or not one should learn, what to do or may need treatment. But it's crude in terms of the fact that there are challenges. Bill,
Imperfect is probably the right word. And look, it was generated based on people that look like us on this stage, right? Non-Hispanic, white people historically drove the normalization tables for BMI. So the AMA says that it's imperfect. It should be used in conjunction with other measures. And I spent 10 years in the Navy. The DoD has figured this out because they use BMI, and then it turns out we have a lot of very fit, healthy sailers.
Yeah, athletes, right?
That had a 30-inch neck.
Right.
And so there are other ways to do body composition assessment that just make sense.
Bill?
Well, I think it's critical to recognize that the BMI is a screening tool, as Nancy said. And the origin of that tool is based on white populations. But all that said, there's very little variation across ethnicities in terms of the utility of a BMI, meaning that if you're a child with a BMI over the 95th percentile, the excess weight is fat. If you're an adult with a BMI over 30, the excess weight is almost always fat. There are these exceptions. The NFL, most notably, and some of your sailors. But I think that it misses a lot of people who don't have a BMI of 30, or a child that doesn't have a BMI, the 95th percentile, who has excess body fat and an unhealthy distribution. That's the other thing, is that the distribution of body fat has a noted impact on morbidity and mortality. Central obesity, visceral obesity in the abdominal compartment is a really risk factor for significant comorbidities, because body fat is not just this repository of fat. It releases all sorts of inflammatory proteins, which is another driver of the consequences of obesity.
What would be your advice as we wind down in time of people watching this who have the disease, who have obesity? What should they do? Where should they go for help? Anyone?
I think the challenge is finding a provider who knows what they're doing.
Okay.
As Nancy said, obesity is a heavily stigmatized condition.
Yes.
On the level of race. And that means that providers come into this, and providers are one of the most, the group that stigmatizes people the most. And most people with obesity have had a bad experience with their medical provider, which means they avoid care. And that, in turn, predisposes them to lack of screening for breast or cervical cancer, for example. So the first step is to find somebody competent and who will listen and who understands the disease of obesity. Part of that falls on us to train those providers. Most medical schools don't have a course on obesity, don't teach students about obesity, don't teach them the language to use to talk about people with obesity as opposed to obese people. So it starts with us, but that patient, I think, needs to find a provider and a provider that is familiar and understands how to use these medications, and that the medications are not the only solution, that has to be surrounded by environmental changes.
Jesse?
A piece of this relates back to that education piece. The AMA has made a major investment, nearly $50 million, in our nation's medical schools and training programs around our Accelerating Change in Medical Education program to try to spur innovations like making sure that our upcoming generation of students and trainees understand how to appropriately treat patients, how to reduce that stigma. We always tell people, talk to your doctor. And I will say that there is something very powerful when a patient is empowered to seek the help that they want.
Nancy, got a minute left?
Oh, yeah.
Closing thoughts.
So I would say we are going to be launching our Bill of Rights, and we are going to start a campaign, a national campaign called the Right to Obesity Care. And we hope that we can get enough attention, again, to at least start educate people and make them feel better about themselves. And our Bill of Rights is aspirational because we know that a number of things we want to have done, for example, for people to be able to ask their doc whether or not he or she is trained in obesity and not have a bad result from that, is to build this workforce, and we thank you very much for that. But I think right now we need good information, credible, respected. Julie Guberding talked about this whole idea of this trusted discussion. Well, the first thing I think we could do, we could all agree, and I know you were working on this, but I think we absolutely say that starting now, that we do not allow people to be disrespected. That if you go into a physician and she fat shames you, that we should not tolerate that. We really shouldn't. And I don't know what kind of mechanisms are necessary for that, but we could stop that. We could stop that now, and that would do a lot right now to start changing the dynamic.
Well, we've run out of time. Please thank our great panel for an important issue on obesity. Thanks so much.
Thank you.
Thank you to our panelists. Next, join me in welcoming our final headliner, Dr. Celine Gounder, Editor-at-Large for Public Health for the KFF Health News and CBS News medical contributor, in conversation with Cheyenne Daniels from The Hill. Welcome back.
Thank you. Doctor, thank you so much for being here with us today. I want to start off, when I was speaking with Dr. Gerberding, we were having a conversation about trust and how we build trust in between our medical and science communities and our particularly communities of color. But one thing that we have seen coming out in recent years is disinformation. And you yourself experienced medical disinformation with the death of your husband. And I want to ask first how you are holding up, how that disinformation impacted you, but then how disinformation and conspiracy theories impact the ability to build trust with other communities.
Yeah, so Saturday will actually be the 1-year anniversary of his death. And so it's very much on my mind at the moment. When he passed away a year ago, I knew that one of the first things that was going to happen was that was going to be used and weaponized by people wanting to spread conspiracy theories about the COVID vaccines. So I had served on the Biden-Harris Transition COVID Advisory Board, was obviously speaking publicly about COVID vaccines, and my husband, being the wonderful, supportive spouse that he was, would support that messaging himself in his community. And I was very much in sort of crisis management mode after informing my family of, I know this is going to happen because this is what happens, this is the playbook, and we need to address it right away. And so I fortunately got a lot of support from the administration to get him flown back so we could get an autopsy done here in the United States. They ensured chain of custody of his body and personal belongings. And then the New York City medical examiner was also very gracious. Normally they don't do autopsies if you don't pass away in the city limits itself. But they did the autopsy for us anyway, and we were able to put out a statement just a couple days after his passing, which I thought was really important because to let people know, here's the cause of death. Of course, I wanted to know myself. My husband was only 49. He had just turned 49 when he passed away. And, you know, I, as a physician, was wondering, did I miss something? Could I have done something? And So partly it was therapeutic for me to know what it was, that it wasn't something that we really could have picked up earlier, could have done anything about in the absence of knowing the diagnosis ahead of time. And it was also really important to get out there that this was unrelated to COVID or COVID vaccines. And initially that did tamp down the disinformation. But then many of you will remember Damar Hamlin had the cardiac arrest due to commotio cordis on the field, and that kicked things up again. So basically every time there's been a sudden death, and I quote sudden death, among young, seemingly healthy people, it has kicked up that same disinformation about my husband. And I have been challenged by some of these people, just like Peter Hotez, one of my friends and colleagues, to debate some of these folks. The problem is you don't debate what is true or not true. I mean, that's just not how you arrive at facts, right? And I think there's a real misunderstanding that it's not about rhetoric. That's not how you arrive at the truth. And so I declined all of those challenges. But you know, it has been challenging because to have to manage all of that along with just, you know, losing my husband was very hard.
Yeah, carrying on. How, when we see disinformation like this, and as you mentioned, we see it crop up every time a supposedly or seemingly healthy individual has a sudden death or health scare, how does that then impact your profession of being able to encourage individuals to see a healthcare provider, get the vaccines that they need, or even continue working with an administration that is pushing for those same things?
The way I approach working with patients, and I still do see patients a little bit of the time, but also people in the community, whether that might be a community health board or on television or in my writing, I think the most persuasive thing is to show that you care. And it's less about the facts, frankly. And I'll give you a couple examples here. A very good friend of mine is a relative of Leticia Draza, who's the health commissioner in Baltimore. And this is probably December, January, when the vaccines were just getting started to be rolled out. Her mother-in-law is high risk for COVID, and especially at that time since she wasn't yet vaccinated. And she was resistant to getting vaccinated. And so I was just curious, you know, what was her thinking, what was her logic? I wasn't really going into the conversation wanting to convince her. So we probably spent about 45 minutes just talking. She lives in Baltimore City. She works as a security guard. I asked her a little bit about, you know, what was it like working as a security guard during the pandemic? What kinds of accommodations did her employer provide her? Did she have PPE? Did she have paid sick time off? And then at the end of the conversation, she said to me, oh, I thought you were going to try to talk me into getting vaccinated. And I said, no, you know, like, do you have any questions? I'm happy to answer questions. She asked maybe, you know, 2 or 3 questions. And then I thanked her for her time. And then I get a call from my friend who says, well, what did you do? And I said, what do you mean, what did I do? And she had just signed up to get vaccinated. So, you know, I think a lot of times it's less about the facts per se. It's more about these other less tangible things.
And it's interesting to me because this is something that we heard from our previous panel, the last previous panel discussing obesity, is there has to be that sort of empathetic and understand human approach, which makes me think about you have another focus. And I like the way it's phrased as diseases of despair, because it brings forth this element of that humanity. There's an emotional element to this, and I would love for you to talk and explain what diseases of despair are.
So I'm not the one who coined that term. That's Ann Case and Angus Deaton, husband and wife duo at Princeton, who have done a lot of the economic analysis behind this notion of diseases of despair. But that encompasses mental health issues, in particular depression, anxiety, and suicide, opioid overdose, alcohol-related morbidity and mortality, as well as gun violence-related deaths. And what we have seen in the last decade or so is a drop in life expectancy first among white Americans in rural areas in particular, lower income areas, or people in particular. But we've now also seen that in other racial and ethnic groups. And so what is driving some of that? Some of the hypothesis is that this is really about the decline of things like manufacturing and the economic impacts on some of these communities. But I think it speaks also to health being a lot more complicated than what happens in healthcare or even public health departments. When you see a drop in life expectancy, how are we addressing that? And can a hospital, for example, really solve that problem?
It's interesting to me because when you point out these issues, mental health, the opioid crisis, gun violence, these are all issues that are top of mind for a lot of voters right now as we gear up for 2024. How do we make sure, going back to disinformation, that disinformation isn't what's driving voters when it comes to trying to make health decisions or who to cast their ballot for, but rather, again, the facts of things and again, the emotional human element of it?
Yeah, I think unfortunately some of our own public leaders are spreading much of that disinformation, and I think as members of the media, it's really incumbent upon us to be fact-checking in real time as much as possible and holding people to account as much as possible as these things are being said. For example, has been this cluster of what's being called white lung, which is basically what we as physicians call ARDS, pneumonia among children in China. And very quickly, that was being, you started to hear conspiracy theories. Is this the new Wuhan virus? Is this, related to a similar cluster of cases in Warren County in Ohio? And unfortunately, one that has real impacts on people and their fears and reliving sort of what happened during the pandemic. Two, confuses people about what to do and to keep their children safe, right? And I think continues to pollute some of the discussion of these public health issues in a way that's not productive.
Yeah. So then I guess it's a big question. What would you like to see our political leaders, whether that's at the state or the federal level, do at this point in time when it comes to addressing not just healthcare, but the disinformation that is surrounding healthcare at this moment?
I think also it's broader than just healthcare. And I think this is a mistake that we make, whether it's healthcare or public health. We're thinking about it in those silos. It's much broader than that. So, whether it's Ukraine or whether it's, gun violence and what works for gun violence or whatever it is, very often it's the same actors that are pushing out this disinformation in a very coordinated way. And to better understand across some of these issues, industries, how this is being done and to work more collaboratively and not just isolate ourselves to a focus on healthcare per se, I think would really strengthen our ability to address some of these issues.
Absolutely. And doctor, we haven't even begun to talk about, we are going into cold and flu season. Actually, we're kind of already there. There's concerns again about COVID. It never actually fully left us, we know. So looking at everything that's happening in our discussion even today, is there one thing you're most focused on at this moment in time?
Oh, gosh. There's so many things to be focused on at the moment. Unfortunately, we just saw that recent shooting in Nevada. And, there have been several more mass shootings just in the last couple of weeks. Some of them in private homes, so they tend to get less attention when that happens. And unfortunately, there are now discussions in Congress about curtailing the funding to the CDC for gun violence research. And for many years, that was not allowed. That was could not be done. And finally, over the last 4 or so years, we have seen that kind of research being funded. And so that's certainly top of mind. How are we continuing coming out of the pandemic to strengthen public health? Unfortunately, I think we did not learn the lessons of the pandemic. And we actually find ourselves in a weaker position than ever should there be another pandemic like we saw with COVID.
Doctor, my final question for you. I do want to hopefully leave with a little bit of positivity taken away from today. Are there things, though, that you're looking at that have been, that we've taken positive strides in, things that you're hoping are going to maybe help change the way that we have been doing some of these things?
I do have some optimism about some of the younger folks who are concerned about climate change and are also having conversations about climate change and the impact on health. And I think that is an area, whether, again, you're in healthcare or public health, we really need to be thinking about and getting out ahead of. And so the fact that there are young people who are concerned, who are engaged, I think is optimistic for me.
Dr. Goddard, thank you so much for being here with us today. I appreciate you.
My pleasure.
Thank you to our moderators and to all the amazing guests who joined us today. That brings us to the end of our program. On behalf of The Hill and our sponsors, CVS Health, AstraZeneca, and Novo Nordisk, we'd like to thank everyone who joined us here today and those who tuned in online. If you missed any portion of today's discussion, it will be available on our website shortly. And thank you very much to everyone, and have a great day.